Hello everyone. Once again, warm welcome to Kochi. Thank you so much for joining us here. We'll start our first lecture at 8:30. I would request those who are taking food, please take the food and listen. If we have a long marathon session, please don't blame us at the end if we start late or don't stick to time. As it is, as per the schedule, the lunch is being scheduled at 1:45 p.m. So if we get late, lunch also will get delayed. So I request those who have had breakfast, kindly be seated.
A pleasant morning to all of you. We welcome you all to the CME Lifestyle Medicine for Doctors and Family. This is a family CME organized by the National Neonatology Forum, India, in association with Department of Lifestyle Medicine, CMC Vellore, hosted by IAP Cochin in association with IAP Kerala, NNF Ernakulam, NNF Kerala, Cochin Obstetric and Gynecological Society, Kerala Federation of Obstetrics and Gynecology, and Physicians Committee for Responsible Medicine, USA. Lifestyle medicine is a novel branch of modern medicine in 2004 that uses the evidence-based strategies to prevent, treat, and reverse lifestyle diseases. These include diseases like obesity, type 2 diabetes, hypertension, heart disease, malignancies, and recently autoimmune disorders and mental ill health, all of which are driven by chronic inflammation. With a demanding lifestyle, burnout has become a significant concern for many physicians. It is crucial to prioritize lifestyle improvements to address this issue in our modern era. The epidemic rise of non-communicable diseases, driven largely by unhealthy lifestyles, affect both patients and healthcare professionals alike. Traditional medicine primarily manages symptoms with lifelong treatment, whereas lifestyle medicine takes a transformative approach by addressing the root causes. Through epigenetic modifications, it reduces inflammation and reverses disease pathology, offering the potential for true remission. A growing body of scientific evidence supports the paradigm shift, highlighting the power of lifestyle interventions in achieving lasting health outcomes. Once again, a hearty welcome to you all to the CME. Now, we will move on to the first session. Let me invite the chairpersons, Dr. Ramesh Chowdhury, Professor, Pediatric Medicine, Consultant in Charge, NICU, SMS Medical College, Jaipur. I invite you, sir, to be one of the chairperson of this session. Thank you, sir. Dr. Loba Dalal, Consultant Pediatrician at St. Goban Advanced Children's Hospital, Anand, Developmental Pediatrician at Sopan Center for Child Development and Behavior. I invite you, sir, to be I invite you, ma'am, to be the chairperson. Dr. C. Sailam Kotur. He is a consultant in Ganga Saraswati Children's Hospital, Nizamabad. I invite you, doctor, to be the chairperson of this session. We often say lifestyle is medicine, but how do we measure its impact? Lab investigations offer the proof we need, translating the lifestyle changes into tangible results. Let's explore the latest insights where the future is headed. Let's hear it from Dr. Renji Jacob. She is a consultant pathologist, head of operations in Metropolis Healthcare Limited, Palarivattam. I welcome Dr. Renji Jacob for the lecture. Over to you, ma'am.
Hello. Hi, good morning everyone. Good to see all the energetic and vigorous faces. Hopefully, we'll have a very energetic day ahead. So, without further ado, let's start the first session for the day. My topic is lab investigations in lifestyle medicine, the current perspectives, the current insights, and the future perspectives. As we all know, before starting with the investigations, we'll just touch on the lifestyle medicine part. So it is a medical specialty that uses lifestyle change as a primary modality to treat chronic conditions. Basically, we have behavioral evidence-based science that allows us to do interventions which will help us to manage chronic diseases. So epidemiological, ecological and intervention studies have repeatedly indicated that most chronic illnesses, the prototypical ones being the cardiovascular diseases, cancers, type 2 diabetes, are the result of lifestyles which are fueled by poor nutrition and physical inactivity. The goal of lifestyle medicine is to empower individuals wherever possible to take control of their own health and well-being by making improved and sustainable choices about their lifestyle. So more than 80% of the chronic conditions could be avoided through the adoption of healthy lifestyle recommendations. 80% of the population wants to live a better life, but they do not know how to pursue it. So this is where the healthcare professionals will come into play. Minimal information is given by healthcare practitioners on how to implement an effective long-term plan to achieve health. So this has to change. So we are in the midst, so this is a beautiful sentence which I found from Dr. Polina. We are in the midst of a patient-led medical revolution. Patients wanting to take care of their health and lifestyle medicine is at the forefront. So before starting, so now I'll just start with the routine investigations and then we'll go to the high-end investigations. The most important, the lipid profile. Lipids, as we know, they are hydrophobic. They require the lipoproteins to basically get transported and to reach their destinations. So we have different types of lipoproteins which involves the low density, high density, intermediate, VLDL and your chylomicrons. So these are the cutoff values which I've just given. Like triglyceride level has to be around 150. LDL cholesterol levels, which is having the most abundant cholesterol in it and also colloquially called as the bad cholesterol. It has to be around 100. Anything more than that is said to be atherogenic, causing more risk of atherosclerotic or cardiovascular heart disease. HDL cholesterol, also called as the good cholesterol. Why so? Is because it helps in removing the cholesterol from the peripheral tissues back to the liver and then it is taken out. So that is why it's called as a good cholesterol. So the more you have it, the better. So anything less than 40, we say there is a risk factor for heart disease. Cholesterol total, desirable said to be around 200. And one more thing which is very now seen very much used by the clinicians is the cholesterol HDL ratio. Has to be between 3.5 to 5. So anything more than 5 is said to be not desirable. C-reactive protein, again a pentameric protein which is produced by the liver whose level rises in response to any kind of inflammation. It's a sensitive marker for chronic low-grade inflammation as well as a predictor of atherosclerotic vascular disease evaluation. It also rises in certain physiological states like pregnancy, diabetes, obesity, but a moderate increase may be seen in even chronic diseases like your autoimmune diseases, rheumatoid arthritis and SLE. A very high disease or a severe degree of CRP rise will be seen in acute bacterial infection, acute viral infections or sepsis. Food for thought, studies have shown that when doctors are involved in lifestyle change intervention, patients are more successful in making long-term behavior changes. D-dimer is a product, and next investigation is the D-dimer, which is formed during the blood clot formation and breakdown process. So the platelets are bound by a dimer or a bond, which is called as the D-dimer. So when the clot breaks, the D-dimer goes into the blood, and this is particularly measured. So it is a better predictor of coagulopathies, especially your pulmonary embolism, deep vein thrombosis, DIC, used as a screening test along with your imaging techniques. Is used to rule out thromboembolic events, and whatever I just said is just listed over here. We know D-dimer, especially from the COVID season, because we know how much important it was to assess the coagulopathy in COVID-19 patients. HbA1c, glycated hemoglobin in blood, is used for monitoring the hemoglobin, which is basically coated with your glucose. So it gives you an average of sugar control in the last 3 months. That is because the RBC lifespan of 90 to 120 days, and that is why you get the control of that many days. Okay, so the trends in HbA1c, rather than the value, the trends play a very important role. So you see the trends in the past 1 year, how is it going? Whether it is going on a higher side, whether it's going on a decreasing side. So if it's going on a decreasing side, that means the patient has a very good control on his sugars. So that is important. Excellent control when it is between 6 to 7%. 7 to 8 is fair to good control. Anything more than 8 is unsatisfactory and very poor control. HPLC method is the gold standard for evaluation of HbA1c. Scenarios where lifestyle modifications has allowed physicians to not start medications has happened, and so many examples are there in front of us because of that. We have cases wherein hemoglobinopathies will cause very unreliable results in HbA1c. So in such cases, we use another test which is called as a fructosamine. Fructosamine is something wherein the albumin will be involved, and that will give us an average glucose of the last 2 to 3 weeks, not the 3 months as HbA1c. That's a difference. Insulin is a hormone which is secreted from the beta cells of the pancreas. Fasting is around 2 to 25. So we correlate with your fasting glucose levels. Insulin high, normal or slightly high fasting glucose, that means your insulin is there but it is not working. That means you have an insulin resistance. That shows that is the development of a type 2 diabetes mellitus. Whereas if you have just the opposite, that is you have a normal insulin level but your fasting glucose is low. You have a normal or a high insulin level, but your fasting glucose is low. That shows your insulin levels are high, which is causing a reactive hypoglycemia. So that can be because of an insulinoma or any other thing which is actually causing an increased insulin secretion. Whereas your fasting insulin is low and that is causing increased glucose, that is because something is not allowing your insulin to get secreted. That might be the start of a type 1 diabetes mellitus, or it might be something in the pancreas like a chronic pancreatitis or a pancreatic tumor or a pancreatic cancer. HOMA-induced insulin resistance test, we have, this is like a mathematical calculator which takes into picture the fasting glucose level along with the insulin values, and it gives you a value, that is your HOMA IR value. So anything above 1.8, we see that there is increased insulin resistance. So this is important when we are doing any lifestyle modification or lifestyle intervention is done. To monitor this, to keep a check on this value every now and then helps. Because if it gets lower and lower, that means your insulin resistance is decreasing. So physical activity, diet changes, anything, HOMA index will help you. So that is what is also written in bold: inherent beta cell function, insulin sensitivity, assess response to diet. This is what I just said. C-peptide fasting is again something related to insulin. Insulin rises, C-peptide rises. So there is a formation of pro-insulin to insulin with the help of certain enzymes. So in that process, we have the C-peptide also formed. So anything where you have an increased insulin, the C-peptide also will rise. For example, it will be increased in insulinomas, chronic renal disease, obesity, insulin resistance, but it will be decreased wherein there is insulin depletion, as in case of type 1 diabetes mellitus. This is the same thing, assessment of residual and beta cell function. Especially you can also assess the success of islet cell transplantation and for monitoring after pancreatectomy. This is just a beautiful statement I found in between, so I just put it. If a lifestyle is not your medicine, medicine becomes your lifestyle. Adiponectin is the next one. I'm just going fast because a very limited time is there. Adiponectin is the most abundant peptide hormone which is secreted by white adipocytes. So the more higher the adiponectin is, the better is good for our body. Like for example, diabetic patients will have very low levels of adiponectin, and also these patients will be also at risk of coronary heart disease. So it helps in monitoring effects of lifestyle changes on metabolic health too, adiponectin. So depending on the BMI, we have the ranges. LP plateau is another cardiac risk marker. This is a lipase which is involved in the hydrolysis of the acetyl group of platelet activating factor. This participates in the oxidation of your low density lipoprotein, which is atherogenic. So increased LP plateau will go and cause a vascular inflammation as well as high cardiovascular risk. So atherosclerosis, obesity, hypertension, metabolic syndrome, diabetes, dyslipidemia. In all these conditions, you are going to have an increased LP plateau. This is what we just discussed. It plays a pivotal role in the pathophysiology. That is what I said, the oxidation of LDL. hsCRP, just like your CRP, this is also detecting your C-reactive protein, which is synthesized by the liver, but this is more sensitive. It will detect even traceable amounts of very minute amounts of CRP in your blood. So that is why it's called as a high sensitivity CRP. And the most important thing about this is it helps assess a cardiovascular disease risk. Other than that, the other things, chronic inflammation, metabolic syndrome, monitoring response to anti-inflammatory therapies. So this is the cutoff. More than 3 is bad. It is your cardiovascular risk. Apolipoproteins are just like your lipoproteins. These are carrier proteins. Also helps as cofactor. So apolipo A1 is a good apolipoprotein because it's a major functional protein of your high density lipoprotein. So it is a fat removal particle. Basically it removes your, helps in removing the cholesterol from your white blood cells outside through the liver to outside your body. So that is a good thing. So ApoA1 has to be high for, decreased atherosclerosis. Also, ApoA1 in brain is said to decrease your neuroinflammation, decrease plaque formation, as well as prevent cognitive defects, which is seen in Alzheimer's disease, as well as preserves memory. So it has a very beautiful effect on the brain as well as in the tumor. It provides a hostile environment in the tumor itself. So these are the uses of ApoA1. ApoB is the primary apolipoprotein of all the other lipoproteins other than HDL. That is your LDL, IDL, VLDL, as well as lipoprotein A. There are 2 forms of it, ApoB48 and ApoB100. Okay, these are high value. So ApoB is said to be the bad one. So the hallmark of atherosclerosis is the presence of cholesterol-rich, low-density lipoproteins and ApoB. Okay, so a high ApoB-A1 ratio indicates a high risk of developing cardiovascular disease. So this is what I just said, the pictorial description. Homocysteine, again an amino acid, very important for assessment of coronary artery disease, stroke and deep vein thrombosis. It is also seen higher levels, is seen in nutritional deficiencies of folate, vitamin B6 and B12. Levels are increased in various diseases like your cancers, ovary, breast, and high levels of homocysteine also can lead to blood clots or blood vessel blockages. Maternal hypohomocysteinemia is associated with increased risk of pregnancy complications, as we all know. Gut microbiome, just touching on that because I know there's a session in detail. So healthy gut is not just the absence of diagnosed disease in the gut, like how the health definition is not just merely the absence of disease. It is the mental, physical and social well-being of the individual. So just like that, we shouldn't have any discomfort or any signs of dysfunction in the gut. So that is when we will call the gut as healthy. Okay, so we will need a gut microbiome, that is your microbes. It will be in a diverse population. It might not just be microbes. You will have your fungi, viruses, all these genera will be present in the gut, but in a proper balance. Any imbalance in this gut microbiome will lead to different kinds of diseases, which we will look at. So there is a dynamic, and also one peculiar thing is the dynamic nature of the gut microbiome, because it can change depending on whatever is the external factors. Like for example, if you have an external environmental exposure of chemicals or drugs or antibiotic use for a long term, this balance will be lost. Also your internal factors like your host immunity, your bile acid, your acidity of the gut, all this will again cause an imbalance. So this is what I said. Right, so diseased one is not just the absence of the disease, not a healthy gut. It is basically absence of all of this. That is absence of all these symptoms as well as discomfort. So what do you actually mean by a healthy gut is you should have a proper absorption, proper digestion. There should be synthesis of vitamins. There should be a proper immune response. There should be a regulation, antioxidant production. Metabolites are needed to be formed. That is your high short chain fatty acid, low risk of infection. All this together will help us to know that it is a healthy gut. So, pictorial description. So, if you see, the diversity is very important. More diverse the population, more better, and less risk of getting diseases. Diseases like inflammatory bowel disease, irritable bowel syndrome, liver diseases. Okay, so cancers, all that. Diversity, then your composition, depending on what kind of bacteria are the highest. Okay, that also makes a difference. For example, if you have the probiotic which are highest, like your lactobacillus or your bifidobacter, anything of that, or any of the genera which are higher, that actually gives a more importance or it gives a more benefit. Then we have different types of gases. We also, I have shown these gases also over here. Depending on the bacteria which are present in the gut, you will have the gases. This is important because certain type of gases which are produced by the bacteria is correlated with certain diseases of irritable bowel syndrome. For example, hydrogen sulfide will be correlated with the diarrhea which is seen in irritable bowel syndrome, whereas methane will be correlated with the constipation which is seen in irritable bowel syndrome. So that becomes important. Resilience of the gut microbiome is shown here is because the gut microbiome is really resilient. That means you have short-term changes, it will not change. There will not be an imbalance. They have that inherent plastic nature in it which will keep it like that. Only when you have long-term changes, like for example Western diet, or we have environmental exposure, or we have food additives, or we have antibiotics used for a long term, all of this will cause a change in the gut microbiome. So that is a long-term change. Otherwise the microbes are very much resilient in the...
Excuse me, ma'am. You have 5 more minutes left.
5. Okay.
Yeah.
Yeah. So, and these are the metabolites which are again important. These are bioactive compounds which are produced by all this gut microbiome, which is very important to regulate your immune response, to maintain your anti-inflammatory nature of the gut. So these are very important, like your short chain fatty acids, tryptophan derivatives, they are important. The pH is important, 5.5 to 7. This particular pH will be important for the healthy gut microbiome to be there. Inflammatory markers, that is calprotectin in stool or lactoferrin, will be useful to know if there is any kind of imbalance or kind of inflammation in the gut. So these are the basic 3 lines of defense mechanism. One is your gut microbiome. The other one is your gut barrier, third one is your liver. So as you see, anything coming externally will go through all of this. It will first go and affect the gut microbiome, which will cause an imbalance in it, which will in turn cause diseases. Anything outside, like for example processed foods, these food additives or processed foods will cause a leaky gut barrier, leaky gut, which will cause the toxins to go from your gut to the outside to the bloodstream, causing diseases. And the third one is your liver, which will detoxify all the metabolic compounds. Processed foods, just an example, which causes increased intestinal permeability, is what I said just now. The same things are just repeated over here. You can just go through the same things again. So gut microbiome, the same thing. So what we have, gut microbiome testing, right now in Metropolis, we are not doing it in-house because we do not have much of sample load. So maybe with more awareness, we will get more and we can start it in-house. Now we partner with another lab and we are doing the gut microbiome testing. What we give in the report, I do not have the liberty to put in the report format here because it is not our own report, but what will be there and what we are planning for this year is what will be there in the report would be the kingdom distribution, the bacteria, viruses, RK, the normal amount, okay, how much high is it and what risk it is, top abundant bacterial species, okay, in what amount it is present, the diet preference that the person will be having, like, more likely, it is all said and more likely, like for example, it is not like 100%, but it has more chances that the patient will be, or the person will be having all of these things. Then there would be, vitamin levels also, like for example, this will be decreased, B12 is decreased, K is decreased or in normal. So depending on that, there will be diet recommendations. Then you have regulation, short chain fatty acids like butyrate, acetate, propionate, all of this will be there, the normal levels will be there and the increased levels will be there. Then the probiotic biome or your pathogenic biome, the levels and the increased or decreased status. Telomere and aging, the specific telomeres are the DNA protein structures which are found at both ends of chromosomes. As each cell divides, what happens is the telomeres will decrease in size. Okay, so the older the cell, the more shorter the telomere, like this picture. So what happens is telomere shorten with age and rate of telomere shortening may indicate the pace of aging. What happens is telomere length shorter than the average telomere length for a specific age group has been associated with increased incidence of age-related diseases. Like for example, accelerated telomere shortening is associated with all these health problems like your coronary heart disease, diabetes, increased cancer risk, osteoporosis and more importantly, cancer. Okay, so here is where your lifestyle modifications will come into play. Physical activity will help in this form of thing. 30 minutes of physical activity, a diet change, more of fibers, more of antioxidant-rich food, okay, more of fish. All of this will actually help us to, maintain the length of the telomeres. There's something called as telomere biological disorders, which are a spectrum of genetic disorders where you will have a germline variance in the genes which are encoding the maintenance of the telomeres. It is a very labor intensive and a very very high-end test to basically measure the length of the telomere. So diagnostic laboratories don't do this, but what we have is big institutes which are specializing in that. They might do this, but these are the different methodologies which are there. You have the flowfish test, that is your fluorescence in situ hybridization along with flow cytometry. Telomere restriction fragment measurement by southern blot method, quantitative PCR method, or you will have your very ultra short telomeres that also can be formed from high throughput single telomere length analysis. Then Tesla is another thing which can find out short telomere lengths, that is your telomere shortest length assay. So these are the methodologies and these are the different tests, but it is very labor intensive and very much complicated, so it is not right now done in diagnostic labs. So maybe along the line, maybe we'll start doing it depending on the cases that we get. So genetic testing, DNA-based wellness, this is basically the DNA testing of the entire body. So here what we have is, you will have like the saliva sample given, a saliva swab will be taken, and all this will be there in the report. So this is your genetic testing. So what will be there is your traits, 1 minute. Yeah, traits, that is your sports. Sports in a sense, you will have, what kind of muscle fibers do you have? Like you have a fast muscle fiber or a slow twitch muscle fiber. So depending on that, the recommendation will be there that you can go for this kind of sports, this kind of fitness regimen. Nutrition will be in terms of vitamins which are present. Skin and hair will be like the color of your hair. They will tell you like likely to have the dark colored hair, likely to get freckles, likely to get tanning. This is your skin and hair. Male conditions, basically the PSA levels. Behavioral is whether it's likely to have some diseases in the future. Also, we have food allergies like your peanut allergies, and diseases are all these disorders like cardiovascular disorders, your stroke, your long QT interval, your cardiomyopathy, hypertrophic cardiomyopathy, gastrorenal. All these diseases also will be told about. That means it is a predictive thing, but it is not like 100% you're going to get it. But you will have an idea of whether you can have it or not. And depending on that, you can do some lifestyle change. So carrier status, basically of some diseases like G6PD or phenylketonuria. Drug response to certain drugs, like most common drugs like your statins or your anti-diabetics or your clopidogrel or your warfarin, whether it is a sensitive, whether it will be a poor sensitivity, whether you will have some drug-induced toxicity, drug-induced hemolysis, all of this will be picked up in the genetic testing. And then at the end, you will have a detailed genetic report with respective recommendations. What is supposed to be done? Like for example, you have a CVD risk, they will help you to give you the recommendations in diet, what you're supposed to do, what kind of physical activity you're supposed to do, fruits and vegetables to be increased, so all of that. Right, so just a few things. Only doctors can cure patients. And small steps make a big difference, especially if there is a consistency in it. Yeah, so thank you.
Thank you, ma'am. That was a truly insightful talk. The house will be open for discussion after the second session. Every now and then, a study that changes everything we thought we knew. The next wave of research isn't just informative, it's transformative. Let's dive into the studies that could reshape clinical practice in the years to come. We have the topic, landmark studies that will revolutionize the current practice of modern medicine in the coming years. I request Dr. Esther Indrani, Department of Lifestyle Medicine, CMC Vellore, to speak on the topic. Over to you, ma'am.
Respected dignitaries on the dais, dear doctors and the families, a very good morning to you all. The next 20 minutes, we are just going to breeze through the history and see the landmark studies that have shaped the medicine that we practice today. So let me start with what is lifestyle medicine all about. It is an evidence-based medical specialty which uses lifestyle, meaning optimal nutrition. What is optimal nutrition? A predominant whole food, plant-based nutrition, physical activity, stress management, adequate sleep, hydration, social support, and avoidance of risky substances as therapeutic interventions to prevent, treat, and even reverse lifestyle-related chronic diseases. So how does this differ from conventional medicine? So the conventional medicine, we see the symptoms and we treat them. Whereas in lifestyle medicine, we look for the root cause and treat it at that level. So this is the lifestyle disease iceberg. So I want you to see the tip of the iceberg, which is what we see in our clinic. We see cardiovascular diseases, we see cancers, chronic respiratory diseases, diabetes. Those are not the root cause actually. Going down to the root cause means you dig a little deeper, the hidden chunk of iceberg which is underneath. So the metabolic risk factors, and underneath them is actually the behavioral risk factors like the unhealthy diet, physical inactivity, substance use, stressors. And even beneath that are the social determinants like the influence of media, market, literacy rate, poverty, globalization, industry, politics. There are so many other things which finally show up as the tip of the iceberg, which is what we see in the clinic. So that is where lifestyle draws our attention to dig a deeper and look into the person who is sitting in front of you, into their behavioral risk factors as well as their social determinants. So that's what makes lifestyle practitioners a little different from the conventional practitioners of medicine. So let me show you the biological pathways which tie up all these underlying risk factors to the diseases that we talk about. So on the extreme left are the unhealthy diet, sedentary lifestyle, stressful environment, poor sleep, addictions, and social issues. So when they are there, they lead to chronobiological disturbances. As we just heard, microbiome alterations, epigenetic changes, oxidative stress and cellular injury. There will be impaired metabolism. And all these finally lead to a final pathway of chronic inflammation, which lead to the non-communicable diseases that we see. So where do we intervene? So we intervene much at the root cause level. The pink boxes show that the lifestyle interventions start much at the root cause level. And even there is a role for reversal and treatment when you even intervene at the phase where they already have chronic inflammation and they are being seen with the diseases. So hence the 6 pillars of lifestyle medicine: nutrition, physical activity, stress management, restorative sleep, social connection, avoidance of risky substances. So let me take you to show how cutting-edge lifestyle medicine right now is, and I'm going to lay before you through various studies through history as a case for disease reversal, remission, and cure through lifestyle medicine. This is just a statement by the ever-famous medical statistician, Sir Austin Bradford Hill. We always look at the chi-square test and then say it's not significant. But mind you, it's an excellent servant but a bad master. So some of you from the medical fraternity would be aware of the Bradford Hill criteria, where we look at certain criteria to say that this is the cause of a disease. So when we talk about lifestyle related diseases and blame lifestyle risk factors to be the causal factors, I want you to run through each of these qualities and fit in the studies that we have and show you how evidence-based lifestyle medicine is. So who talked about disease reversal of diabetes? Much before the physicians, the surgeons did. So bariatric surgery did show that diabetes could go into remission. So that's when we were awakened to the fact that we should also be thinking in that lines. So hence the ADA has defined partial remission, complete remission, prolonged remission of diabetes. These are the criteria, and all of them are without medications. So what is the strength of association of lifestyle and diseases? So this is a study, very interesting study done among Pima Indians who were living in Mexico versus those who were living in US. Pima Indians have a specific genotype which predisposes them to diabetes. So the first graph shows that the pointer is not there. Sorry, it's there. So this is the people who are living in Mexico. So the non-Pima Indian Mexicans and the Mexican Pima Indians. When they are within Mexico, meaning their lifestyle complies with what the Mexicans do, the incidence of diabetes is about 5 to 7%. Whereas the same Pima Indians, when they live in US, look at the diabetes rate, it's about 30 to 40%. So what is different between these two is the environment that they're living in, and they went on to do an analysis of their diet, their physical activity, and what they found, their diet was much, much lower in fiber when they were living in US, the US-based diet, and the majority of calorie contribution was by fat. And if you look at the physical activity levels, of those Pima Indians living in Mexico, it was 32 and 22 hours. Over here, it was almost in single digits. So this shows that the same genomic constitution, when they are adopting a different lifestyle, you can see that the disease manifests there. So that is in coherence with what Dr. Esselstyn stated. Genetics do load the gun, but lifestyle pulls the trigger. So, okay, did that just happen by chance? So we have a more temporal case study here. This is a study done in Cuba. So when Cuba went through a crisis, the country was in financial crisis. So the red shows when they were in the crisis, the green shows when the country flourished economically. So when there was an economic crisis, the Cubans switched to a lifestyle which was more physically active, calorie-reduced diet. You can see that the physical activity of the individuals in Cuba skyrocketed during the famine period. And then you can see it slowly came down once the economy sprung back. Similarly, you can see that the smoking prevalence sort of fell when there was an economic crisis. As we look at the disease pattern, this shows the incidence of obesity and obesity-related complications. So during the famine, when the physical activity was at the peak and the calorie consumption was restricted, there was a drop in obesity and other disease prevalence. Whereas you can see there's a steep rise as the economy sprung back. So what happened during this time of testing for that country? The Cuban officials did buy massive imported cycles from China, and all the Cubans were using cycles as their main mode of transportation versus any automobiles, because the country didn't have enough economy to afford automobiles. So that's why the previous graph that I showed you, there was a steep rise in the physical activity rate, and that's what contributed to the decrease in obesity and lifestyle-related diseases. They also switched back to their agriculture, traditional ways, and the diet was much of what was ingrown in Cuba versus the high caloric imported diet. So this shows that there was something that happened and lifestyle changed and the disease changed. And lifestyle reverted back and disease did revert back. So is there a consistency across the many studies which are done? Of course, yes, and across many diseases and across many studies we see that consuming a whole grain, cereal and fiber-rich diet contributes to reduce metabolic syndrome as shown across the years across many different studies. Let me quickly run through some of the big studies that have been done. Adventist mortality study, Adventist health study. These are large studies which had thousands and lakhs of population studied. They were all prospective follow-up studies, and they looked at mortality, which is a hard outcome. And all these studies do favor a healthy lifestyle to be protective against all risk factors that contribute to NCDs. So this is from Europe, the North Karelia project. It's a very famous project where the nation did adopt a healthy lifestyle through policy changes. And then you can see there is a steep drop in mortality in the whole of Finland as evidenced in this graph over the years. It's across many decades. So the smoking rate, the salt consumption and the animal fat consumption, you can see it had dropped by 50%, salt consumption did drop, and smoking dropped by almost 1/4 of what it used to be. So this is what has contributed to the drop in mortality. So this happened when the whole nation adopted healthy lifestyle as a policy level change. So these are some more humongous studies done among thousands and lakhs of population, NERSA's health study and the Framingham heart study. Some of these studies are still ongoing, following up the offsprings, which are showing consistent association with disease, decreased disease rates and mortality when they follow a healthy lifestyle. Leon heart study, I'll be touching upon it a little later in the coming slides. And the EPIC study, which showed association of high red meat consumption, also refined meat consumption with strong association and causation with cancers. So as many of you are taking care of children, this is a recent report showing that a nationwide study which showed that sugar rationing in the first 1,000 days of life did protect against chronic diseases as they grew up. So how specific are these? So you can see that there are 3 different graphs which show that this is a diet which is low in fruits, vegetables, and dairy products. This is a diet which is enriched in fruits, vegetables, and fiber. And this is a diet which is enriched in fruits and fibers as well as low in fat and cholesterol. You can see that as the diet gets better and closer to whole food plant-based diet, you can see that the drop in blood pressure is much more pronounced. This is the Lionheart study that I said I would focus a little bit more on. You can see that Mediterranean diet versus the standard Western diet followed up for about 5 years shows a steep reduction in cardiovascular event rates. So there is also a biological gradient, meaning that the benefit improves as the diet comes closer to a whole food plant-based diet, as evidenced here. As you move towards a diet which is poor in animal fat and rich in whole plant-based products, you can see that there is a gradation to the protective effect. So this graph also shows the same. As the percentage and grams of fiber keep increasing, the protection from all-cause mortality, cardiovascular diseases, diabetes, cancers, all of it show a consistent increase as the diet becomes better. So this is from Sherlock Holmes. He advised Dr. Watson, when you have eliminated the impossible, whatever remains, however improbable, must be the truth. So as we talk about disease reversal and remission, when we say that it's not possible, as the evidence show, it becomes improbable, but it should be the truth. So is there a biological proof to it? So diabetes is a well-known disease, and by the time they are on insulin, we say that the usual theory is that the beta cells are all dead and gone. But the current hypothesis is that the beta cells were never dead. So they actually de-differentiated into alpha cells, and as you apply the lifestyle changes, they actually re-differentiate and get reprogrammed into the original beta cells, and that is where the disease reversal and remission of diabetes comes into play. So do we see this as a coherent truth across all sorts of lifestyle diseases like inflammatory bowel disease, rheumatoid arthritis, which are all autoimmune diseases, which we also call as lifestyle-related diseases? Yes. So as we switch the lifestyle of a patient with inflammatory diseases into a healthy lifestyle pattern with fiber-rich plant-based diet, we can see that the gut microbiome fully switches to anti-inflammatory group of microbiomes from a pro-inflammatory group. This has been proven and established, and they offer all the benefits of...
Excuse me, ma'am, you have 5 more minutes left.
Yes, thank you.
Thank you.
So these are some more graphs showing that with a high fiber diet, the inflammatory markers and the disease activity scores do come down, and the microbiome switch to anti-inflammatory microbiome. And so this is about reversing heart disease. Are there any experiments which show this? Yes. So this is a very age-old study by Dean Ornish et al. Done in the 90s, published in Lancet, showing that the atherosclerotic patches do completely reverse after just lifestyle changes. This is in the era where statins had not yet become the standard of care. So he had a head-to-head comparison with those taking statins versus those who were not on statins. So lifestyle changes were the only ones which showed reversal of the atherosclerotic plaques, whereas statin group did have actually progression. So some of the diabetes remission trials which are ongoing and some of which have been completed, I just want you to show that there are umpteen number of head-to-head, well-done, randomized interventional trials which show diabetes remission sustained up to 5 years and 10 years. So this is a reality that we are talking about. So finally, sometime back when insulin was discovered for type 1 diabetes, this was the statement released in New York Times. So one by one, the impeccable enemies of man, the diseases which seek his destruction are overcome by science. Diabetes, one of the most dreaded, is the latest to succumb. So this, they were talking about type 1. I hope we will be able to say this for type 2 by the time we change our lifestyle. So what are the take-home points? Can we as people who are sensitized to the umpteen number of evidence available, can we make this lifestyle prescription as a mandatory prescription for each patient that we come across as well as for our families? So in a nutshell, I can say nutrition, plant predominant diet, whole grains, 3 to 4 servings of fruits and vegetables, handful of nuts and seeds. Exercise, resistant training twice a week, aerobic training minimum 30 minutes a day for at least 5 days a week. These are minimum. And the benefits are more when you push the timing and the duration up. Sleep, at least 7 hours of continuous sleep, chronobiologically matched. Stress reduction, social support, and stop substance use. So the way ahead, there are global bodies, national bodies, and institutional level bodies which are working towards it at various levels, offering service to patients, educating, integrating lifestyle medicine into UG and PG training and research. Multicentric trials in the Indian context are all underway. And this is what we offer in CMC Velour, the PG Diploma in Lifestyle Medicine course. This is our first batch of students and second batch is going on. And this is the book that we recently published, Lifestyle as Medicine for the General Public. So this book touches upon the evidences, the practice points, and practical implementational tips for each individual. So this is a team at Lifestyle Medicine that I would like to recognize at this moment. Thank you all for your time.
Thank you, ma'am, for the wonderful session. Now I request the chairpersons to open the house for discussion. I request Dr. Esther Inbarani and Dr. N.G. Jacob to be seated in the stage.
To Dr. N.G. Jacob, you did mention about the lipoprotein little.
I dropped the lipoprotein A, but that is also a part of it. I just kind of took it off. But it is one of the major blood tests that is needed to be done along with the lipid profile. But it is important. I just took it out because there was a lot of things to be added. So I just took it out.
Is overhydration a problem, or what do you suggest?
So I'm coming from a physician background. So we do deal with this now. Velour is in the high temperatures, and we do have patients with heart failure with reduced ejection fraction. So hydration, when somebody has a compromised heart or a renal dysfunction, has to be tailored to that patient's functionality. But somebody who has a normal heart function and normal renal function, we tell about 3 to 4 liters per day. If the ambient temperatures are high and if they are exerting more, even more than that. So there's no fixed limitation for a normal person, but for somebody who's got a compromised cardiac function and renal function, it has to be tailored to their output and functionality.
What about pregnancy?
Pregnancy, it's actually in pregnancy, physiologically, the plasma volume increases a lot. and it's a hypermetabolic state. So it calls for little more hydration than normal. So there is no limitation of the hydration. It actually should increase than what would have been their baseline.
Okay, thank you.
I mean, one of your slides which compared the vegan diet with the semi-vegetarian and all. What I found is a semi-vegetarian and vegan doesn't have much difference in the graph.
Yeah, so the first slide that I put up was by the statement by Sir Bradford Hill. So the chi-square and the difference that we see are all, it's a man-made structure. So we just say that, okay, if the p-value is less than 0.05, only then I take it. So that construct itself is a man-made construct. So when we have such large numbers and such consistency across all studies, just going by that confidence interval, crossing each other, doesn't really make sense. If all the studies are saying the same thing, it's hard that it's not the truth. And sometimes we get so much carried away by this p-value and the confidence interval, and then we really look for that statistically significant difference. But that's why it's a good servant, but it's a bad master. If we just conclude saying that, okay, I don't see a significant difference, then we lose the real truth. So all of these statistical constructs are just trying to move us towards the truth, but they are not the litmus test for the truth. So we need to look for consistency across the studies. What does the whole amalgam of the whole evidence body drive towards? So it can never be that single study or that one study. So that's why today I actually pulled up multiple studies done across the globe to show you the conglomeration and the heaviness of evidence that is available. So that was just one study which did show a gradation, but if you look at the AHS study and the AHS mortality study, all of them show even more a stark difference between a plant-based diet and a non-plant-based diet. So the evidence altogether is in the direction favoring a plant-based diet. So that one slide was just to show that there is a gradation when you see that. I agree that from a statistical standpoint of view, the confidence intervals are overlapping and it will not be a statistically significant difference, but there is that gradation which is appreciable.
We have 2 more minutes for the open house.
What about the use of curds in the diet, in our diet?
Use of curds? Yeah, curd is a good source of probiotic, so nothing against curd. But if we actually talk about predominant plant-based diet, we look forward for the benefit of the fibers which are in the plant predominant diet, which are not there in animal diet. If you take any form of animal-based diet, the fiber in there is actually nil. And if you look at the plant-based diet, you have fibers which are present in good amount. Like for example, millets. It's about roughly any millet would give about 8 to 12 grams per 100 gram of millet, which is compared to nothing in the animal-based protein or a carbohydrate that you get. As well as even if we look at the quality of the fibers that we get, the plant fibers have both soluble and insoluble fibers in abundance. So they are actually they are the substrates for the colonic bacteria. So the colonic bacteria thrive on that. So the anti-inflammatory bacteria, the gut microbiome that we talk about, they thrive on the fibers which are sourced from plant-based products. So overall gut health is shown to improve and move towards a anti-inflammatory gut microbiome when the diet is predominantly plant-based, versus even isolating those fibers and giving us fiber supplements. It's become a fashion now. There are some studies which are being done, where fiber is being fed to the patient in scoops from bottles for diabetes control. So they don't show this shift in the gut microbiome towards a healthy set of flora. They do show some glycemic control because that's sheer fact that fiber is there, reduced gut motility is there. Some of it is there, but all the benefits do come when it is a plant-based diet, because by virtue of the way it is made, the way the plants are designed by God, it's more health promoting across all the biological plausibilities that we discussed.
think both the speakers were excellent, and it's beyond the scope of 25 minutes to elaborate all the lab investigations. Though you summarized well regarding the sleep, I think majority of us physical activity and nutrition we are stressing. I think sleep also plays a major role, and that's important is 7 hours of continuous sleep. I think majority of the time it's not practical. Could you just stress upon the sleep pattern of continuity and how it modifies many of the diseases?
My last question to Dr. Renji. In clinical setting, how frequently we should be monitoring lab investigations? Investigation, but how frequently? Like every yearly or according to the condition of the person?
Depends on the symptoms. Like for example, HbA1c, you're getting an average of every 3 months, 90 days lifespan. So that has to be like every 3 months you have to do it. So along with that, you will anyways do the sugar levels and everything else. But otherwise, at least over 6 months or 1 yearly gap. If you are symptom free and you do not have any family history and anything else, then at least 1 yearly or annually you need to go for a checkup and do a basic profiling if you do not have any symptoms. Otherwise, the frequency increases in case if you have anything or if you have a family history.
You mean to say that those with risk factors, I think they need
yes, they need more frequent. If you do not, if you're clean, like which is very rare with individuals, but if you're really clean and you do not have anything else, then an yearly or 6 monthly is enough. But if you have something, then it is better to go for a 6 monthly or even lesser than that frequently, depending on what it is. If you have a risk factor or any of that. Now that we are coming through the era of these lifestyle modifications, it will become even more, the frequency will increase because you'll have to monitor those lifestyle interventions, whether it is working or not. So for that, then the frequency will increase.
Thank you, ma'am. I now request the chairpersons to present the memento to the speakers. All of you are requested to come to the center of the stage. The memento is being given to Dr. N.G. Jacob. And the memento to Dr. Esther Imparani. Thank you all. Thank you, chairpersons, speakers, and the delegates for your active participation. And we will move on to the session 2. I invite the chairpersons for the session 2, Dr. Lelan K. Bharti, HOD Pediatrics and Neonatology, JPC Hospital, Delhi. I welcome you, sir, to be the chairperson of the session 2. I now invite Dr. Sanjeev Wazir, Director NICU, Motherhood Hospital, Gorgon, to be one of the chairperson of the session 2. And I invite Dr. Venkatarama Rao, Head of I request Dr. Venkatarama Rao to be one of the chairpersons and come to the dais.
I think Dr. Ramarao is yet to arrive. Please carry on.
Good morning. And when I was a resident and doing my residency, the only food group I knew was the instant noodles, which you could get in between the, whenever you get time. Now, as pediatricians, we are always kind of forced by parents. Is this medicine could be a little bit more tasty? Now, there is a way to look at it. Could the tasty food be a good medicine? And it is time for us to really dig into the common sense and get that tasty meal into a medicine in a common flavor, science and common sense built into that plate, so that we can work better for our children, and of course for ourselves and our patients who are adults also.
So good morning everybody. At the outset I would like to thank the organizer, especially Dr. Manoj, for having me all, and my compliment and congratulations to all of you. And so in this session, we'll be having two incredible speakers. And they will be discussing Dr. Banita Rahman. And first talk will be by Dr. Banita Rahman. She is an internal medicine physician and clinical doctor at Physician Committee for Responsible Medicine. Currently, the principal investigator in trial investigating role of the online nutrition education program in weight loss and diabetes reversal, and a clinical instructor in medicine at the George Washington University School of Medicine. So without further ado, may I request Dr. Banita to come over and start her lecture. Banita, stage is over, yours.
Good morning, everybody. Are you able to hear me okay? Yeah. Well, I'm so delighted to be here, and I'd like to thank all of you for being here and Dr. Manoj for inviting me. I'm really excited to speak to you about GLP-1 medications because I think they're about to start making a lot of noise in India. So let's get started. So this is India Express from 2 days ago, I think it's Friday's newspaper. What stands out here is not Elon Musk's picture, but the clipping right next to that US firm's weight loss drug is coming to India. And a lot of your patients will be asking about them, your family members. So what I'd like to do today is share the research evidence. And this article really caught my attention because it shows that the medication is tirzepatide, which will be branded as Mounjaro, and it will cost over 14,000 rupees a month. So let's talk about how effective this medication is. I'll start with some food trends in India, definition of obesity and overweight, talk about GLP-1 medications, what they are, what they do, nutrition-based approaches, and causes of obesity. First, let's talk about food trends in India. So this used to be our traditional Indian food. I think this looks familiar to most of us. Rice, the thali, it was made of legumes and whole grains and vegetables, and we put it together with lots of herbs and spices. Well, the food today looks a little different. If you go to any food court, there's a lot of Western fast food coming in. This is a typical mall in India. This one happened to be in Mumbai, but you can go to any mall in any major city and see the same trend. So there's a lot of Western fast food coming in. But it's not just Western fast food that's making an impact. Our Indian food has changed. So we're consuming a lot of fast food style South Asian food. What do all these foods have in common? They're all deep fried. They're all heavily processed. Very little in terms of fiber and a high caloric density. And this is driving changes in Indian health. And so what we're seeing is that over the past few decades in South Asia, including India, people are consuming more processed foods, more high-fat foods, more added sugars like sodas, fruit juices, and fewer whole grains, vegetables, legumes. And in turn, we're seeing a rise in chronic disease, obesity, acne, PCOS, hypertension. You all see this every day in your clinic, so you know this is happening. It's important that we define what obesity is. Now, I think everyone here is probably familiar with the BMI, but it's important to know that the BMI definition is really based on race and ethnicity. So this is the first column, shows the BMI that the World Health Organization has set. But this really applies to people from Africa and Europe and the United States, Australia, so people of African or Caucasian ancestry. But then the World Health Organization has a criteria for Asians. But then a few years back, a group of Indian experts said, we need a whole other criteria for Indians. So what's really remarkable here is that as South Asians, we're considered overweight at a BMI of 23 and obese at a BMI of 25. So how many people were familiar with that cutoff? Can I get a show of hands? Okay, great. So why is that? Why is the threshold for obesity so much lower for Indians? And that has to do with our body composition. So at any given height and weight, we carry more body fat. We carry it mostly in our belly area, and belly fat causes a lot more problems cardiometabolically than fat in the hips or thighs. So our risk for diabetes, cardiovascular disease is much higher. In fact, we develop diabetes and heart disease 10 years earlier than most populations, and we're much more likely to die from them. And this doesn't just apply to Indians, it applies to the whole Southeast Asian region, which is home to 25% of the world's population. Now, this study shows that different populations develop cardiometabolic problems at different BMIs. And what I really want to emphasize is that while someone from Europe develops it at a BMI of 25, look where we start to develop problems close to a BMI of 20. We start to see prediabetes, elevated blood pressure, abnormal lipid profiles. Let's talk a little bit about the role that lifestyle plays. And what we see is that, nutrition, exercise, tobacco, alcohol, these are lifestyle choices that we control, and they impact the risk of chronic disease, such as body weight, high blood pressure, our blood sugar levels, dyslipidemia. And then these conditions progress to life-threatening conditions like cardiovascular disease or cancer, which eventually lead to death. Now, if you were going to intervene, where do you think it's most effective to intervene? How many people would intervene at lifestyle choices? Okay. How many at chronic disease? How many at life-threatening conditions? Well, and it's too late at death, right? So, but in our current model, this is where we intervene when someone develops a chronic condition or a life-threatening condition. And while these interventions are useful, they can be life-saving immediately, they do not reverse the disease process. To do that, we really need to intervene at lifestyle choices. That's where we can be most effective. And this is the burden of chronic disease in India. Some people think the obesity prevalence is closer to 40%, and you can see that what's really shocking here is 80% of Indians have an abnormal lipid profile. So the risk of cardiovascular disease is quite high. Let's talk about weight management. In a nutshell, we consume energy in the form of carbohydrates and protein and dietary fats, and another one, alcohol. People often forget alcohol has calories too. And then we expend energy in physical activity, in movement, just our basic metabolism, digesting food. And when we consume more energy than we're using, we gain weight and we hold on to it. So the question isn't whether we're consuming more energy. The question is, why are we consuming more energy than our body needs? Has anyone ever seen a little baby eat? What does the baby do when she's done eating or nursing? She kind of turns her face, pushes the breast or bottle away, and that's because babies are intuitive eaters. They know when they've had enough, and we were all born with this intuition. But what do parents do when the baby stops eating? We encourage, we force, we cajole, we bribe, we distract, because we think they need more. So the programming starts at a very early age. Don't listen to your body, listen to your environment. And this can eventually turn into a habit of eating more than our body needs. So what drives us to eat more? There are internal factors, such as feeling very hungry. When we get very hungry, we tend to overeat. Emotional eating is a big issue for many people. We are getting ready to start a study on binge and emotional eating. Late night eating, habit, values. On holidays, we eat more. At birthdays, we eat more. And then there are external factors like the nutrient density of food. That's something we'll focus on today. Portion sizes, distractions, the sight or smell of food, and drinks add a lot of calories. Alcohol affects our appetite. When we drink, we eat more. Medications like steroids, corticosteroids rev up the appetite. So all of this drives us to eat more, which leads to weight gain. Well, don't worry, because the pharmaceutical industry has a solution for this, right? It's called GLP-1 agonists. How many people have heard of these medications? Can I get a show of hands? How many of you have prescribed them already? How many of you know someone who's taking them? Okay. All right, so today what I'm going to do is break down the research evidence about these medications. What are GLP-1 agonists? So these are glucagon-like peptide 1. These are new medications. They're usually given by weekly injections. There are 2 approved medications for weight loss, semaglutide and tirzepatide. They both lower blood sugar. They were initially developed for diabetes, but the manufacturers discovered they cause significant weight loss. So now they're really being promoted for weight loss. The reason they lead to weight loss is they suppress our appetite. So people don't feel hungry. They also delay the rate of gastric emptying. So food sits in the stomach longer, people don't feel hungry, they feel full longer. So let's talk about the first one, semaglutide. Its brand name is Wegovy or Ozempic, depending on the country or the formulation. Now, semaglutide is available in India. I believe the cost is about 10,000 rupees a month. And it does cause significant weight loss, about 16%. But there are also significant risks and limitations with it. Because it's an injection, it causes injection site reaction. Because it delays gastric emptying, it can cause significant nausea, constipation, bloating, discomfort. There's some research showing risk of thyroid cancer in animal models, risk of pancreatic issues, and then risk of optic neuropathy, which I'll show you in a little bit. So not a benign medication, but significant side effect profile. Now, most of the studies on semaglutide were funded by Novo Nordisk. It's a Danish company that has the patent on this drug. So this is the step 1 study, and it investigated the role of semaglutide in weight loss and what happens after it's stopped. So let me draw your attention to this right here. This is the group that was placebo. They did not get anything, and you can see they experienced no weight loss over 120 weeks. But this is the group that did get semaglutide. Let me see if I can use the pointer. So this group did get semaglutide, and you can see for the first 68 weeks when they took it, they lost significant body weight. But then they were told to stop the medication to see what happens. And look what happens as soon as they stop it. The weight comes right back. Now, the study was stopped at 120 weeks, but I think we can be fairly confident they're going to continue to regain the rest of the weight. So this is one of the biggest problems with these medications, is as soon as people stop them, the weight comes back. this is the SELECT study, which investigated the role of semaglutide over a 4-year period. And the results are really interesting. What we see is that these individuals continued the medication for 4 years, and the weight loss plateaus around 65 weeks. After that, there really isn't much more weight loss. But this is the slide I really want to draw your attention to. It's a very busy slide, but let me just summarize it for you. The bottom line is, after 2 years of treatment, only 12% of individuals achieve a normal BMI. Nearly 45% have a BMI in the overweight category, and 43% have a BMI in the obese category. So for most people, for nearly 90% of people, they will not get to a normal BMI with these medications. In most of these research studies, the average BMI goes from like 37 to 32. Now imagine if in India, 25 is considered obese, that's really not going to be a very satisfactory health result. Now, this is one of the few studies on semaglutide that was not funded by Novo Nordisk, and you'll see why. This was funded by a nonprofit group. These results were published in JAMA Ophthalmology, and what this team did was they looked at the rate of non-arteritic anterior ischemic neuropathy, optic neuropathy in patients who were taking semaglutide. Are there any ophthalmologists in the room? No? Okay. And this is an important cause of blindness in adults, non-arteritic anterior ischemic optic neuropathy. And what they found was that in people taking semaglutide for weight loss, there was nearly an 8-fold increased risk of developing this optic neuropathy. So this is quite concerning, because people with diabetes, one of the most dreaded complications is retinopathy and blindness. And here we're seeing that the risk of another blinding eye condition is increased nearly 8-fold. So these are the take-home points about semaglutide or Ozempic or Wegovy. It does lead to significant reductions in body weight, but it's important to understand the weight loss plateaus around 68 weeks, and the average BMI remains in the obese category. 90% of people will not reach a normal BMI by Western standards. So by Indian standards, it might be an even lower number. And weight gain recurs after people stop the medication, so it needs to be taken indefinitely. And at least in the US, insurance doesn't cover the cost, where it costs $1,600 a month. Here, I understand it's about 10,000 rupees a month. And there are significant questions about long-term safety and feasibility. And it's also associated with very high discontinuation rates, which I'll get to in a few slides. All right, this is the new one that's, some of you, are any of you getting emails about this already from the pharmacists or dispensaries? No? Some of my physician colleagues in Mumbai are already getting emails from pharmacies saying, we will have this, so you can start prescribing. This is called tirzepatide. It's produced by Eli Lilly in the US. It goes by the brand name Mounjaro. It's a little bit different than semaglutide in that it's a GLP-1 and GIP receptor agonist. So it causes even more weight loss, about 16 to 23%. In India, it will cost over 17,500 rupees a month. It's also given by a weekly injection. Now, it has much of the same side effect profile as semaglutide, significant GI effects because of delayed gastric emptying, the injection site reaction, and again, not a benign medication. This is the SURMOUNT study, and this study investigated what happens to weight loss after people stop tirzepatide. And look what we see. So let me break this slide down for you. There are two groups in this study. Everyone started tirzepatide here, but then at 32 weeks, some of the participants continued it and they continued to lose weight. This group was told to stop using it by study design, and look what happens. They regain most of the weight. Now, Eli Lilly only continued to track data for 88 weeks, but I think, again, we can be fairly confident people will continue to gain the rest of the weight. So this is the big problem with tirzepatide, weight regain, along with the other side effect profiles. And in the SURMOUNT study, there were significant side effects. 81% of participants experienced one or more side effects. 16% experienced serious side effects, and 7% discontinued the treatment due to adverse events. Now, this study was just published a few months ago about the discontinuation rate of GLP-1 agonists. And this was a retrospective study. About 61% of individuals did have type 2 diabetes, and these were the 3 GLP-1s they looked at. So most of them are taking semaglutide or tirzepatide. We rarely prescribe liraglutide for weight loss because it's not very effective at all. And what we find in this study is that at 12 months, let me show you the discontinuation rate. These are individuals with obesity or overweight without diabetes. Nearly 2 out of 3 have discontinued the medication at 12 months. And at 2 years, over 84% have discontinued them. Even in individuals with diabetes, nearly half discontinue at 1 year, and at 2 years, 2 out of 3 discontinue them. So the discontinuation rates are very high. And now remember what happens when people discontinue them. The weight comes back. So this is really devastating. And this is a huge issue with any weight loss drugs, including these. So let's summarize the pros and cons of GLP-1 agonists. The pro is they cause significant weight loss, but these are the cons: injection site discomfort, expense, significant adverse events, weight loss plateaus, and most people do not reach a normal BMI. Nearly 2 out of 3 will discontinue the medication at 12 months, and after stopping, most will regain the weight that they lost. Now, why does weight gain come back with these? Why do people regain the weight? Because these medications do not address any of the underlying factors that cause weight gain. They simply mask our appetite. So people lose weight, but then of course once we stop, all the weight comes back because we haven't addressed the underlying issues. So at the Physicians Committee, we're actually doing research into things like emotional eating and binge eating and helping people address the underlying root cause of obesity. So what about the role of nutrition in weight loss? How many have heard of these diets, low carb, paleo, gluten-free? Is that getting more popular in India? How about keto and Mediterranean? And how many of you are familiar with plant-based diets? Okay, so let me go through what that is with you. So a low-fat plant-based diet is a research-proven and effective way to lose weight and keep it off. This is the lifestyle heart trial that you heard about just in the last presentation. What I want to emphasize is the weight loss component of the study. So in this study, individuals were randomized to lifestyle changes or placebo or control group. And what we see is that at 1 year, the lifestyle group has lost nearly 11 kilograms, whereas the control group has increased their weight. And the lifestyle group experienced significant reductions in cholesterol, LDL. And as you heard, this was without statins. So this is happening just by changing the diet. And there were significant reductions in blockages. So low-fat plant-based eating not only causes weight loss, all the side effects are the good ones. And this is a study called the BROAD study. This came out of New Zealand. And what we see here is that individuals were randomized to plant-based diet or standard care, and at 6 months, the plant-based group lost 12 kilograms. So that is really quick. That's 2 kilograms a month. That's significant weight loss. And at 12 months, people are continuing to maintain that weight loss. And again, there's reduction in cholesterol, LDL, A1C. So not only is it causing weight loss, it's reversing cardiometabolic risk factors. And this is a study that our team at the Physicians Committee did comparing standard care with the low-fat plant-based diet. And at 16 weeks, the low-fat plant-based group lost over 6 kilograms. And we did DEXA scans on everyone to assess body composition. And 2/3 of that weight loss was body fat. So it's important for you to know that when people lose weight, they don't just lose body fat. Nobody does. We can't target weight loss like that. It's often 2/3 body fat, 1/3 lean tissue, and that's physiological. There's no way around that. And that's what we're seeing. So people are losing meaningful body weight. And this is not that different than what we're seeing with those GLP-1 agonists, plus a reduction in cholesterol. Now, people often advocate for Mediterranean diet, saying maybe that's a healthy medium. But what is a Mediterranean diet? It's not a specific diet. It's a pattern of eating in the Mediterranean region. And we did a study comparing 16 weeks of Mediterranean diet to a plant-based diet. And again, we see the plant-based diet caused significant weight loss, 6 kilograms at 16 weeks, 2/3 of which is, again, body fat. And there's virtually no change in the Mediterranean group. And we're again seeing significant reductions in cholesterol. So what is a low-fat plant-based diet? Let me define it for you. It is a diet rich in fruits, vegetables, whole grains, and legumes. So this is the power plate that at the Physicians Committee we developed. So whenever people are putting a meal together, they can just pick from these 4 food groups. It is different from a vegetarian diet because it excludes all animal products, including dairy. That includes milk, curd, ghee, all those things. And it avoids oils and fried foods, so really minimizing oils. And then limiting high-fat foods. In all these research studies, people were consuming a low-fat diet and limiting added sugar. So it's not that it's no sugar, it's minimizing the amounts of added sugar. And we recommend a B12 supplement daily. Now, why does this work? How do plant-based foods promote health? It's because, how many people have heard of fiber? How many of you have heard fiber is good for our health? Yes, all of us, right? But how many of you know fiber is a carbohydrate? Okay, some people. So people are often eating these low-carb diets. What they don't know is fiber is an essential carbohydrate that we can get from our food. And it's only found in plants. It has no calories. So plant-based foods have a low caloric density. Fiber is the best prebiotic for our gut microbes. It's the food our gut microbes thrive on. And when people go low carb, they miss out on essential fiber. And plant foods naturally have no cholesterol, whereas all animal products do. And animal products never contain fiber. And plant foods generally are low in fat, whereas animal products are high in fat. So the caloric density of plant-based foods is low, while their nutrient density is high. And they're loaded with antioxidants, which protect us from inflammation, cancer, infection, whereas we know animal products are carcinogenic. So how many people know tobacco is a group 1 carcinogen? How about asbestos? How about processed meat? Aha. So you know whenever you watch a Bollywood movie and the actor or actress lights up, what do you see on screen? A warning label that cigarettes are harmful to health. Do you see those warning labels on processed meat? No, but they should be there. They're in the same category as asbestos and tobacco. Now, this is the macronutrient breakdown of a plant-based diet. It's a high-carb diet, 80%. And carbs are the best source of energy because they include fiber and starch, and they're low in fat. And 10% fat and 10% protein. All right, now let's do a nutrition quiz to wrap up the session. All right, true or false? Dairy is essential for bone health. How many for true? Don't be shy, raise your hand if you believe it. How many for false? How many are not sure? Okay, great. So we have an even split, right? Well, it is false, and let me explain why. Research shows that dairy does contain calcium, and that people who consume dairy products do consume more calcium than plant-based eaters who avoid dairy products. However, this discrepancy doesn't make any difference in bone health. It doesn't impact bone density or the risk of fractures. So consuming more calcium in the form of dairy does not have a meaningful impact on our bone health. And dairy increases the risk of breast cancer. Dairy is rich in estrogens produced by lactating cows and IGF-1, both of which increase the risk of breast cancer. And higher intake is associated with a 22% increased risk of breast cancer. And in some studies, higher milk consumption on a daily basis is associated with a 50% greater increase in the risk of breast cancer. What are women told to do around the time of menopause? Drink milk to protect their bones. Well, as I shared with you, it doesn't protect their bones, but it does increase their risk of breast cancer. And we are seeing that the rates of breast cancer are rising at an alarming rate in India. 39% increase over the past few decades in every single state. And this risk is there even with full fat or reduced fat milks. Dairy for young people triggers acne, again because of the hormones and IGF-1, both of which are acne promoting. So for those teenagers dealing with acne, if they just cut out dairy, they can experience significant improvements in their skin health. Okay, how about this? How many, true or false, plant-based foods don't provide enough protein? How many think it might be true? Okay, some people. How many think it's false? All right, let's look at the research, and it's false. So the first question we need to ask is, how much protein do we need? And we only need about 10 to 15% of our daily calories to come from protein. And how can we get this from plant foods? So fruits are low, 2 to 8%. So if there are people called fruitarians, they eat nothing but fruit, so they're going to be protein malnourished. But look at grains, 10 to 17% protein. Veggies, 10 to 50%. And legumes, 20 to 45%. So on a low-fat plant-based diet, people will get all the protein they need. Okay, true or false? Ghee promotes health. How many for true? Okay. How many for false? How many are not sure? Okay, some. Well, this is false. Right before I left for this study was published in JAMA Internal Medicine, where they looked at outcomes in butter consumption versus plant oil consumption. And what they found was that compared to lower levels, higher levels of butter intake were associated with a 15% increase in mortality risk. And on the other hand, plant-based oils were associated with a 16% lower mortality risk. And replacing 10 grams of butter daily with plant-based oils decreased total and cancer mortality by 17% each. The reason for this is butter is loaded with saturated fat and cholesterol, so it worsens cardiovascular disease risk. All right. How about this one? True or false? Coconut oil is a health food. How many for true? How many for false? Okay. Now I know we're in South India where coconut is highly popular, but I'm sorry to say coconut oil is not a health food. And the reason is because what does coconut oil look like at room temperature? Is it a solid or liquid? It's a solid. And that's because it's loaded with saturated fats. That's the chemistry of saturated fats. They stack. These fatty acids stack neatly, so they're solid at room temperature. And in this study, coconut oil consumption was associated with increased LDL levels, increased non-HDL cholesterol levels, all of which increase the risk of cardiovascular disease. Okay, how about this one? True or false? Soy increases the risk of breast cancer. Have anyone for true here? Some people. How many think it's false? Okay. Well, this one is false, and let me explain where the confusion comes in. So soy contains estrogens called phytoestrogens or plant-based estrogens. Now, unlike pharmaceutical estrogens or human estrogens or bovine estrogens, which increase the risk for breast cancer, phytoestrogens are like a brake. They put a pause on...
Excuse me, ma'am. You have 5 more minutes left.
Okay. Thank you.
Thank you.
And they reduce the risk of breast cancer. And substituting dairy with soy decreases the risk, and women who consume soy have a lower risk of breast cancer, recurrence, or mortality. Okay, last, true or false, fish is essential for omega-3s. How many think that's true? How many think it's false? Okay, well, this is false. Omega-3s are essential fatty acids that we must get from our food. In nutrition, the word essential means we cannot make it, we must consume it. Now, they are a type of unsaturated fat. There are 2 kinds, omega-3, omega-6. Let me show you how we can get omega-3 in our diet. So there are several omega-3 fatty acids, ALA, DHA, EPA. They improve heart and brain health. We can get ALA from plant foods like walnuts, chia, flax, or we can get DHA and EPA from fish, but fish also contains cholesterol and mercury, and it has no fiber. So you can skip this part and get ALA, and your body will convert it to DHA, EPA, and you do not need fish. And it's very easy to get the recommended amounts. You know, half an ounce of walnuts or an ounce will give most people all the omega-3s they need. So we need very little. Let me just end with some practical tips. Instead of using butter or high added fats, use spices, air fry foods instead of frying it, really limiting oily fried food. What did Prime Minister Modi recently ask Indians to do? Decrease their oil intake. This is a big problem. So going back to our basic Indian food without frying it, non-dairy products can be delicious and much more nutritious. Try air-fried tofu instead of cheese. Make a raita or yogurt-based dishes with peanut yogurt or other yogurts. Lots of dairy-free options available. Here's an easy almond milk recipe. We do recommend a B12 for everyone consuming a plant-based diet. All right, let me end right there so we can open it up for questions. I think we have just a couple of minutes.
We'll take the questions at the end of the next lecture.
Okay.
Kindly be seated.
Okay. Thank you, everybody.
Thank you, ma'am, for the truly insightful presentation. So we will move on to the next topic, gut microbiome, gatekeepers of our health, by Dr. Lakshmi Sundar, President, Indian Society of Lifestyle Medicine. I request Dr. Lakshmi Sundar to speak on the topic. Over to you, ma'am.
Good morning, everybody. How many of you in the audience are not doctors? Okay, trust me, I'm going to keep it simple. I know you had a lot of scientific lectures. So, Hippocrates said several centuries back that bad digestion is the root cause of all evil, and the death sits in the bowel. That's a spelling mistake. Death sits in the bowel. This he said long, long ago. And here I am to tell you why gut microbiomes are the gatekeepers to our health. Food for thought. My talk is going to be very infectious, literally, talking about microbes. And it's going to be very contagious. I'll tell you why. Just think about it. We'll discuss over tea. Which of these impacts gut health the most? Do gut bacteria outnumber human cells in the body? Are rice and potatoes bad for health? Are artificial sweeteners really good for our gut health? And also think about what is that one food that you ate as a child. You would go back in time and try and change that. Just think and we will have a chat. So, I arrived in Cochin yesterday, and I always have the habit of taking a walk because I'm a runner. I always check my run route the day before when the light is there. So I called a friend of mine and asked him, how safe is it for women to run in Cochin early in the morning? He said, you are in a health area. The stadium is right there. People are running there. Just take a walk. It's a very healthy area. This is what he told me. I took a walk from here to the stadium, went around and came back, hardly a couple of kilometers. And trust me, every 100 meters, there was a fast food joint. The stadium was surrounded by fast food joints. And they were doing good business. So I was shocked. So this is what we think health is all about. We exercise and we have the right to eat whatever we want. What is a healthy gut microbe? I think Dr. N.G. Jacob spoke most of my talk today, but still, I'll try and fit in the pieces. So, when does the gut microbe start developing? Fetal period, amniotic fluid from the mother carries a little bit of microbes in, but the fetal gut doesn't produce any microbe on its own. There is a difference between the way delivery, vaginal delivery, the baby as it comes out is exposed to the vaginal microbes. There's a difference in the gut microbe between a cesarean delivery and a vaginal delivery. And breast milk. Breast milk has something that is normal, oligosaccharides, which is a fantastic prebiotic. That is why we insist, I'm carrying cold to Newcastle, full of pediatricians here. You know why breast milk is really, really important. And as the child grows, it depends on what the food environment in the house is. So there was a study done between children from Europe and children from rural Africa. By 3 years, your gut is kind of evolved, like whatever you're going to have in the future as a gut microbe is already established by the age of 3. They found a huge difference. Children from rural Africa had certain species of bacteria that were very important for, breaking down cellulose. Whereas children from Europe lacked it completely. So what you feed as a toddler grows up, and those are the microbes that are stuck with you. And no two people have the same set of bacteria. There are trillions of microbes in your gut. Most of them are bacteria, but there are also fungi, viruses, archaea, everything. There's so many different kinds of organisms in your gut. But no two people have the same kind of microbes. Your microbe in your gut is like a rubber stamp. It's very unique to you. And there's a lot of intervariability, and that diversity is so important. And within us also during phases of our life, when we are sick, when we are well, there is also an intra-variability in the composition of the gut microbe. And all gut microbes carry almost the same metabolic functions. The microbial composition can predict health or wellness, or disease. These functions are very essential for health, and there are several factors which we'll talk about that influence microbial composition. So I think Dr. N.G. Jacob already spoke about it. A healthy gut is not only free from diagnosed diseases, but also operates without causing any discomfort or signs of dysfunction. So what is an ideal healthy gut? One that is effectively able to digest, has a phenomenally good gut barrier, it has antioxidants production, high SCFAs, short chain fatty acid production, low risk of infections, and improved metabolism. But most of us fall within the third one, absence of disease or digestive complaint. We still not completely evolved to a perfectly good gut because we still a low fiber consuming population. There are microbes present everywhere in the body: respiratory system, skin, vagina, oral cavities, and the gut. They are hidden organs, considered to be the hidden organs, have much higher metabolic functions than any single organ in our body, and they have contribute to over 150 times more genetic information than that of the entire human genome. There are different kinds. Bacteroids are the most popular ones, most common ones seen in the gut. The proteobacteria are opportunistic pathogens that are present in the gut. And then you also have actinobacteria. Dr. Rahman spoke about GLP-1 agonist. And there is a lot of study going on and using this gut microbe to stimulate what is naturally present in your body. You don't need to go look for a semaglutide. So there is this theory of mutualism which is so important in a gut. So our gut is not just filled with one kind. We have the good ones, we have the bad ones, we have some bacteria that feed off others. There are some which are very mutually beneficial to one another. There are some who take up the job of the other when the other comes down, the number of the other one comes down. So they all exist beautifully. It's a beautiful ecosystem. It's almost like your Amazon forest. There are different kinds of species living in complete harmony when you're in health. The good ones, as I said, are the bifidobacteria, E. coli. E. coli in certain strains can be pathogens, but many of them are very beneficial. Lactobacillus. The bad ones we all know are the Campylobacter, Enterococcus, and Clostridium. So when the gut microbes are not functioning effectively, we call it gut dysbiosis. If you see, the microbes are present right from the stomach. Low counts in the stomach because of the acidic environment. But colon, as you come down, the colon is the area which has the maximum concentration of gut microbes. The microbes have pretty much a role to play in every single organ. The gut-brain axis, endocrine system malfunctions when your gut microbes are not good. Cardiac health, high lipid profile, hypertension, COPDs, asthmas can also have a basic basis in the gut. Liver inflammation, hepatocellular carcinoma, and non-alcoholic fatty liver disease when the gut is not working well, the microbes are not working well. Osteoporosis, bone demineralization, infertility, ovarian dysfunctions, ovarian cancers, colonic cancers, if the gut microbes are not healthy, it can affect every single organ in your body, including your immune system. When the gut microbes are in perfect harmony and are working really well, how do you know? What are the markers? You have the increased short-chain fatty acid production, there's increased antioxidants, reduced inflammatory mediators, reduced pathogens in the gut. The lipid metabolism is excellent. The gut epithelium, the barrier is excellent. Everything, the vitamins are produced, beneficial metabolites are produced, your immune system is fantastic. And you're perfectly in a good metabolic state and a good overall well-being state. There are 3 lines of defense. What has an impact on the gut microbes? Nutrition predominantly, diets high in processed food and fat, dietary fat, food that has additives, artificial sweeteners, your environmental factors like antibiotics, the chemicals, and other factors which we'll talk about, they can affect your gut microbiome. So there are 3 lines of defense. Whatever you eat comes in contact with the gut microbes, that's one. There's a gut barrier that senses and regulates what diffuses across the barrier, and the liver, which potentially removes all the toxins. So what is that marks a healthy gut? When you have diversity of species, the composition with predominance of one particular, it could be lactobacillus, it could be bacteroids, anything, abundance of one particular species. The functionality can be assessed by metagenomics or other enzymatic activities. The gas production, I think Dr. A.J. Jacob already spoke about hydrogen, hydrogen sulfide and methane. A resilient gut, because what you eat can have an impact on your gut. It doesn't take too long to cause a dysfunction. Within 24 to 48 hours, it can show up, it can kill certain strains, or it can grow healthy strains. After an antibiotic, if you've been, antibiotics kill your gut microbes. It takes about a few weeks when you start eating, loading yourself with lots of fiber, your gut health and the gut microbial composition comes back. Metabolites produced by the gut bacteria, 3 kinds. The bacteria feed on the fiber that you give them, fuel them with, produce short-chain fatty acids. The primary bile acids that reach the intestine are converted into secondary bile acids by the bacteria. And also, on its own, they produce certain metabolites like tryptophan, which is important in your gut-brain axis. An alkaline pH is maintained in a healthy gut, and there's reduced inflammatory markers. These are the potential markers of a healthy gut microbiota. So example, if you wanted me to be more scientific, the F by B ratio, Firmicutes by bacteroids ratio, if it is high, it's potential that obesity and other metabolic problems can happen, because Firmicutes is a bacteria that can extract a lot of energy from the food. So this is one ratio that can predict or help in the treatment of obesity. As I said, no 2 people have the same kind of bacteria, but all the good pathogens in our system, good bacteria in our system, perform pretty much the same metabolic function. And this diversity is so important because, as I said, when one bacteria kind of declines, the thriving good population can take over and carry on the metabolic function. So I think the functional capabilities of the microbiome, though it's an ongoing research, has not been captured to its full potential. So it's so important about diversity. I will keep talking about diversity when I talk about gut health. You will know later on why I'm doing that. So to assess gut health and microbiome balance, the key metabolic products are short-chain fatty acids, bile acids, and tryptophan metabolites. They let you know whether the gut barrier integrity is good, whether the immune modulation is good, and the metabolic health is good. As I said, short-chain fatty acids are produced by the bacteria acting on your fiber. And it indicates fiber and fiber fermentation efficiency. Bile acids, secondary bile acids reflect microbial impact on metabolism and gut-liver axis. Tryptophan connects gut microbiota to immune function and neurological. This is very important. A lot of people with borderline depression, anxiety, and other issues, when you start feeding them with good whole food plant-based diet, you see them improving overall, feeling much better. People with mood disorders, changing the dietary pattern helps because of the serotonin production that is produced in the brain. And the gut-brain axis, it's a two-way pathway. We all know, all of us have butterflies in our stomach before something, or when we react to a stressful situation, our gut motility increases, right? We've all felt that some part in our life. That's your gut-brain action. Similarly, in the reverse action also, you have good metabolites
Excuse
like
me,
serotonin
ma'am, you have 5 more minutes left.
that act on the neurological system and improve in your mood disorders. So what happens in disease when you have excessive pathogens in your gut? You don't have the bad bacteria flourish in your gut. What happens? The intestinal barrier, we all know, is a watertight junction. The cells, the barrier is kind of opened up, so there is leakage of toxins into your circulation. That is how the translocation of these toxins and inflammatory mediators are responsible for all the diseases that we talk about, whether it's heart, IBS, liver, CKD, diabetes, and so on and so forth. Cardiovascular disease, we all know, many speakers before me spoke about whole food plant-based diet. One more reason, the gut bacteria convert dietary choline and carnitine. Where does that come from? Animal products found in eggs predominantly, red meat. They convert them into trimethylamine, and this is in the liver converted to TMAO. High TMAO is associated with increased risk of atherosclerosis and heart disease. That's one major thing. I already said about gut-brain axis. A leaky gut can cause a lot of allergic disorders. If the immune system is dysregulated, you could have autoimmune disorders which have the basis in poor gut health. Very simple way, if your gut is working well or not, the poop, which is a powerful window into our health. So type 3 and type 4 is what we look at when we consider it to be a healthy poop. So what makes your gut very healthy? An increased consumption of whole food, plant-based diets, which are low in fat and high in fiber. You don't have to look at curd for your lactobacillus. You get them from the prebiotics that are rich in vegetables and fruits and whole grains. So some of the natural prebiotics, the entire range of your plant food, the natural prebiotic. Aromatics, very high source of prebiotics. Prebiotics are the ones on which the bacteria work and produce metabolites. Probiotics are the live bacteria. Postbiotics are the ones that are produced after fermentation. So there is, being an LM physician, if I don't talk about just 2 minutes, exercise. Exercise, does it have an impact on your gut bacteria? Definitely, yes. Exercise does impact. It reduces the transit time of stools, so reduced exposure of pathogens to the gut, and has a very positive association with healthy gut. Sleep, poor gut health impacts sleep, can cause insomnia. Very important to maintain your circadian rhythm. That's very, very important. When you sleep is very important, as much as how much you sleep. Stress, we spoke about the gut-brain axis. Substance abuses, alcohol, cigarettes, and other substances can destroy your gut health. Now, I talked about gut bacteria being very contagious at the beginning. I'll tell you how. Social connections. When you're socially connected with people, not only you feel happy, you can also transfer some of your gut microbial. You'll start producing almost similar composition of gut microbes. So it's very important to foster very positive social connections, which is a very important aspect according to me for overall well-being. Before I conclude, I always, I'm a big fan of Dr. Will, the gut health MD. I always add this. F goals, that's what he says. What should you eat as often as possible? F goals, very simple. Fruits and fermented food. Fermented food doesn't come only from animals. You have your own kanjis, which are very common in India, the beet kanjis, and down south your ragi and the kambu kanjis, they are all fermented. Plant curds are also fermented, by the way. Greens and grains. By grains we mean whole grains. Omega-3, Dr. Rahman spoke about it. Aromats like onion and garlic, excellent source of prebiotics. Legumes. And your cruciferous vegetables, mushrooms and seaweeds. You don't need fish for seaweeds. Fish eat seaweeds, and that's how give you omega-3. Thank you.
A humble request to all the respected attendees, as a mark of respect to those who are attending the session, may I request those of you who are, engaged in conversations to keep the voice low or go out and talk. Thank you.
Thank you, ma'am, for this session.
Is that okay?
Yeah, sir.
Thank you, sir. Thank you, ma'am. Thanks for your wonderful session. It's really stimulating and enlightening interactive session on lifestyle medicine, and also you talked about some aspects of culinary medicine as well. So this is the first conference we are attending. I'm not sure about our other colleagues, but it's quite interesting. And you talked about all important things about the gut microbiota, how it helps in improving the immunity, and as you talked about the prebiotics, and also you also talked about the other pillars of lifestyle medicine, other pillars, it's very, very important. So it's quite amazing talk. Thank you, ma'am.
So it was indeed excellent talk by both the speakers. Very insightful talk. So house is open now for the question answer if there are any. Yeah.
First appreciation. It was excellent talk. This is question to Dr. Lakshmi madam. You talked about diverse microbiome. Is it always helpful? And some of the African countries, they have done research. The diverse microbiome again causes lots of anti-inflammatory markers are very high in some of the. So regarding the fecal microbiota transplantation, so now the latest research are saying sometimes it can be harmful because you might transfer the pathogenic bacteria also. So please kindly give a.
You can use this one.
No, I'm talking about what is natural. When you improve diversity in your diet, I didn't touch upon it because of short of time. Diversity in diet, in terms of whatever vegetables that you eat, fruits you eat, you also each bacteria feeds on a different fiber, and diversity of the good kind is always helpful. Rather than one particular person doing all the work, you have a team of people doing the work. So that sense I spoke about diversity, but fecal microbial transplants, I'm not talking about what we do as a procedure, but naturally when you eat different fibers, when you bring in a lot of plant diversity, your gut microbes also diversify. And by diversification, I'm talking about different strains of bacteroids or lactobacillus or...
Thank you, Dr. Rahman, for your wonderful talk. That was an excellent talk. You have ignited a controversy in my mind. Actually, I think you are a proponent of pure plant-based diet. I'm a cardiologist. In my academic days, I was learning that fish is good for your health. Nuts are good. And even coconut, I'm not talking about coconut oils. We have learned a story of Philippine Island who is surviving on purely on coconut, but having a very low cholesterol. So these.
May I request the audience to please make silence? May I request the audience once again, please make silence.
So these three controversies, nuts, fish, and coconut, you said no. But in some of your slides, you added walnuts, which may be good, but you said no for other nuts. I need your clarifications if you have anything to add.
Okay, so I think you're asking for clarification about where I said minimize nuts, but then I said you can get omega-3s from walnuts. I'm sorry about the confusion. Let me clarify. So we're talking about eating a low-fat plant-based diet. So we want to keep the fat around 10% of calories, okay? Now, most plant foods are low in calories, especially if we cut out the oil, which is 100% fat. Then you have nuts, like walnuts, peanuts, cashews, almonds, all those nuts, seeds like pumpkin seeds, watermelon seeds, chia seed, flax seeds, all these seeds. Avocados, I know those are not a big item here. Olives, so coconut. So those are the high-fat foods. For people looking to lose weight or lower their blood sugar, we strongly emphasize they keep it low fat. So that means I usually give people a rule of thumb, and I say limit those high-fat foods to 2 tablespoons a day. So I don't mean 2 tablespoons of each one, I mean all together. And that's usually enough to give us the essential fats we need and keep the fat low. So it's not no nuts, it's we want to minimize it for people looking to lose weight or lower their blood sugar.
Okay. Thank you.
What about fish? So for fish, we don't recommend fish in a plant-based diet because fish has several issues with it. One, all fish has cholesterol, so it increases our cholesterol. Fish, especially fatty fish like salmon, tuna, mackerel, those are really high in fat, so that leads to insulin resistance. Even shellfish like shrimp, lobster, those fish are very high in cholesterol even though they're low in fat. And then almost all fish has some mercury in it, which can be harmful, and fish has no fiber at all. So instead of fish, like we recommend things like tofu or lentils or chickpeas or kidney beans or black-eyed peas. Those are loaded with protein, leave people feeling full, and they also have a lot of fiber.
Thank you. So shall I add one more point? Like I think what you have discussed is basically for those who need to lose weight. It's not a prescription for everyone, isn't it? Am I right?
So
because what I'm telling is like you were telling that dairy also should be avoided. And as a pediatrician, whenever we give the nutrition advice for kids, we always tell them that it's the time of puberty and adolescence that we get that bone accrual. And one important source of calcium for them are the dairy products. And there are so many papers as well as meta-analysis which tells us that at least in the teens, that the bone health is better in those who take dairy products rather than those who are not taking it. There are very recent papers and meta-analysis regarding that. Yeah. That is one thing. And another thing is regarding these omega-3 fatty acids. I think our prescription should be based on the region also. Like for example in Kerala, we get fish, which is a good source of that. And personally what I believe is all exclusion diets are for therapeutic purpose. Like when someone is in a need for an acute weight loss, we can try something like that. Otherwise, it should be something which is more wholesome. Thank you.
Well, just to clarify, the research supports low-fat plant-based diets for everybody. The research supports plant-based diets for everybody. It's helpful for human health. It's better for the environment. It's kinder to animals. The low-fat part is recommended for people with diabetes and those looking to lose weight. Teenagers or growing children don't need to keep it low-fat. People at a healthy body weight with healthy blood sugar levels, they don't need to keep it low-fat. But we do recommend keeping it plant-based for everyone, and research has shown that children who eat a plant-based diet thrive and do well just as children who don't. So there's no, in fact, they have better health. They suffer less from asthma, allergies, acne, polycystic ovaries for children. These are common conditions that children struggle through, and plant-based diets help with all of them. And constipation, which is a big problem in children. Yeah.
Dr. Amit, go ahead, please. Standing
So
quite a long time.
Coming from North India, where dairy, wheat and rice are the staple food for us, and we've been consuming that from childhood and have seen our fathers and forefathers consume it. And certainly hearing that, everything of that is bad for our health. So dairy we have stopped using, wheat we have minimized, rice also is on the way out. So of the lesser, which is lesser of the evil between wheat and rice, because Indian population only has either a wheat based or rice based diet.
Just to clarify, we're not recommending anybody stop eating rice or wheat. There's nothing wrong with rice or wheat. We recommend you consume whole wheat, like roti made from whole wheat flour instead of maida. And if you can, consuming brown rice or red rice or black rice instead of white rice. But rice, even white rice is not the problem. It's what goes on the rice that's the issue. Huh? Is what? Yes, so the research study I just shared with you showed ghee, which is made from butter, is associated with higher mortality risk. Yeah.
My question is not based on any scientific studies. It is just based on the natural clues. Everyone was talking about the source of fat and protein from the animal diet is not good for human health. But you just think, when we start our life, a baby, when he consumes mother's milk, and we consider that as a best sources of nutrition. The mother is also animal. Biologically, we are all animals. So,
Excuse me, we are mammals, and the purpose of breast milk is to feed the infant.
yes.
What is wrong is taking the milk from some other mammal and drinking it,
Yes.
not ethically, but even scientifically.
Yes.
That milk is not meant for us.
For protein, that's okay. For the
Protein, I didn't talk about
human milk oligosaccharides, that are okay. But for the fat, fat means triglyceride. When we source it from the cow or a mother, because traditionally when we are feeding the mother milk with fat diet after the pregnancy or delivery, so that alters the fat composition of mother milk. And the same happens to the cows when we rear them in our courtyard. We feed them specific feeds.
Are you trying to say you're getting fat
Yes.
from the milk?
Yes.
No, that fat is not good from the cow's milk. No, we don't need that fat. We get fat. She showed you brilliant sources.
Ma'am, one more question regarding the weight. You are saying about the BMI,
I
but
think
once
this is the last question.
Yeah, sure. Once you start doing exercise, definitely that muscle mass increases, no? So putting the BMI in the 18 to 22 as the normal weight, if you exercise, it's very difficult to keep it that BMI. So you stress upon the BMI. Is it the last word in health?
So I think your question, if I understood it, is about BMI and how accurate it is. What if someone exercises a lot and they're very muscular? Their BMI may not fully reflect. It's true. If two people have the same height, weight, but they'll have the same BMI regardless of their body composition. BMI does not tell us the body composition. It's simply a surrogate. For body composition, we do something like DEXA, which is what we did in our research studies. But for most people, they can have a good sense of it just by assessing belly fat. Some people measure waist circumference, and also looking at cardiovascular risk factors. So if the blood sugar is high, cholesterol is high, that BMI may not be right for that person. Okay, thank you.
One more last question. So far we could make out that we cannot touch any non-vegetarian items. That's what is the ultimate thing which we learned today's session. That's what I feel. But I can understand, I can tell you that there are many people in Japanese areas. They live mostly on small fishes and like that. And they are having they live more than 100 years. They don't fully utilize vegetarian. They are not vegetarians at all. And what about egg? We can touch egg.
So just to clarify, we're not telling people how to eat or what to eat. We're just sharing the science with you, what the science shows and the research shows. Now you can decide how you want to use that information, okay? Thank you so much.
Thank you all. So now I request the chairpersons to present the mementos to our speakers. I request all of you to come to the center of the stage for the memento presentation and the photo session. The mementos will be presented to both the speakers, Dr. Vanitha Rahman and Dr. Lakshmi Sundar. A memento to Lakshmi Sundar ma'am. Thank you, chairpersons, speakers, and all the delegates for your active participation. And now, we will break for the culinary demonstration and tea. The next session will start after 10 minutes. You can have your tea and we'll start the session after 10 minutes. Thank you.
So actually those of you are here, kindly turn your attention to there, or you can go near there, or from there it will be projected here. It was just to, I request all of you not to take anything personal here. What we are discussing here is evidence and science, and there will be a lot of areas where we feel there will be controversies. Let us not make any prejudgments. We are not here fanatic. We are actually not politicians or terrorists or anybody. We are scientists. Let us look at everything, form your own opinion. Let us not impose things on others. This is a humble request, because I can see the kind of emotions that are running. Let it not run. This is being challengeable anywhere. You can challenge it. What we are discussing here is pure science. Now, just for those of you who are interested in culinary session, this is culinary session. Now we have a small demonstration of 2 items, how you can make at home healthy, and then you can taste it also. The demonstration. May I request Solomon to turn it over to there, and then you can, yeah. Sorry?
You can project it here. We can talk it from here.
I think you project it there, huh? Okay. We'll assemble back at 10:45 for the next session. Yeah, it will be shown. He's taking the video. Just give me a second.
Dr. Bindu.
Solomon, you need it there.
Switched on, okay.
Just switch on this mic.
Yeah. So we have 2 gut-friendly recipes here, probiotic rich. One is the fermented tea, which I think most of you have already tasted.
Just hold on, let the video come, because...
Okay.
No, he is bringing it. Where is he? Just give him a minute.
Yeah,
kindly give space for him so that the others also can see.
Sauerkraut, fermented cabbage. Can we start?
No, wait, it's not come. Please start.
Yeah. So we have two gut-friendly recipes here. One is kombucha, the fermented tea, which most of you have already tasted. So I'll just quickly tell you how to make it. So originally both the recipes are from China, and then they went over to Germany and Europe and Russia and things like that. So we just boil tea, make a black tea with 5 grams of sugar in 100 ml of water, means around 50 grams in 1 liter of water. We boil, we cool it down, and then we add SCOBY. So this is the culture. This is the culture that we put on the tea, on the cold tea that we prepare, and you put it in a jar like this, and just put it in a cool dark place and let it ferment for 15 days, around 15 days, and then you get the fermented tea. So this is SCOBY. This is called SCOBY, symbiotic culture of bacteria and yeast. So bacteria, yeah, yeast and bacteria, yeah. So bacteria like gluconobacter and acetobacter. So this is the cellulose actually. This bacteria makes cellulose. It looks a little not very good, but this is just cellulose, and you can even eat this, or the sediments that come on it also you can have. So this is just very probiotic rich. And these are the samples. Anybody who's interested to ferment their tea at home can take it. But today only you make a tea and then put it in a jar and close it with a cloth. No, so you can keep culturing it. The culture you can keep it for years actually. You just need to put the substrate. The substrate is sugar. So sugar is just 5 grams in 100 ml, and it keeps on reducing also because these bacteria and yeast thrive on that sugar. So the sugar levels come down actually. And so it's very antioxidant and polyphenol rich. And the other recipe which I'm going to demonstrate is fermented cabbage, sauerkraut. This is called sauerkraut. So we need cabbage for that. So clean container, clean and dried container, because otherwise if the contamination occurs, then the fungus can grow. So, and you can just wash, if you're very particular, then maybe 2-3 layers you take out and wash. Otherwise, if you want, you can even wash the whole leaf. But washing it, the normal running water is fine. No need actually, because this, when the bacteria and all grows in it, actually it becomes detoxifying for us. The bacteria does the detoxifying job for us. So. No, but plain water is, running water is enough. Yeah. And you can add the spices of your choice, whatever you want to add. So I have got some garlic here. And the chili I'll put later, because otherwise the hands will burn. And here's some carrot if you want. You can experiment with other hard vegetables like beans or cauliflower and things like that. And what you have to do is take the salt. 1 second, excuse me. Yeah. You have to take non-iodized salt, because the iodine will interfere in fermentation. So non-iodized rock salt will do, Himalayan salt will do. Especially the crystals will help in, so the concentration of salt is 2% here, 2 to 5%. So 2% works fine. I'm not measuring it right now. And with the salt, you just have to break the cell wall of the vegetable. So it will release water. You have to keep doing this for around 5 to 8 or 10 minutes. So it will release a lot of water. It will reduce, the volume will reduce to 1/3 actually, and I'll be able to put it in this. And you have to massage it well and just press it with your hand. So you have to use hand, because this fermentation is lactobacillus fermentation. You can use purple cabbage. You can put beetroot in this. And in regarding that also, you can use different flavors. You can use ginger, and you can even add chia seeds to it. No, you just make it. Yeah. So you just have to prepare the tea and add it to the tea and keep it. No, don't strain it. Yeah, yeah, you can use it. Like it will remain when you're consuming. No, the volume will get reduced. Then you add another fresh. Yeah, yeah. So even the liquid becomes probiotic, and if you transfer the liquid in another bottle, 1/3 of the liquid and the rest, yeah. So it will form a SCOBY on the top layer. So please, anybody who's interested, is just very limited number. Anybody who's interested can take it. Yeah. So you must use it today, otherwise it will, 1 liter of tea you make. Some places, in Kerala I have not seen. Yeah, Amazon it's available. No, don't keep it in the fridge. Just make tea today and then culture it otherwise. Because there is no liquid, SCOBY will die. The bacteria will die if you... Yes, 1 liter. Tomorrow for what? The recipe, please demonstrate, put it on the screen, the recipes. So, no, you have to make tea and add the culture. Yeah. And then you are telling, we can use it for subsequent... Yeah, later after it's fermented, that 1 liter tea, you can make more out of it. And we can also store it means like there is something called second fermentation. So because this produces carbon dioxide, so after 15 days you can bottle it. Means put it in the bottle and you can mix some flavors of your choice, some apple juice or something. And then you can use it from the fridge. Yeah, so because the bacteria, it's harnessing the natural bacteria from the, yeah. Yeah, you can take it, it's good. Pickle kind. So we'll be serving at the lunch time, we'll be serving this. I've made this, so we'll be serving this thing, already made thing. This 4 days, Kerala, yeah, 4 days it will ferment, then you need to keep it in the fridge. You can keep it for months. So you can see it's already started releasing water. It's okay. Fermented, yeah, fermented, cooked. That, yeah, with the curd and the chili and... Yeah, it's about diversity, different bacteria you get. The more the diversity, better the health. So it's good. It's better. You should keep it in the glass. Kimchi, different strains, actually. Sauerkraut. Yeah, because it's getting more antioxidants and all from the vegetable itself also. Fiber is there. So fiber is prebiotic. So you can keep it in the fridge for months. You can use it like a side dish. You can use it in sandwiches. Yeah, it starts reducing. No, you have to use your hands. Yeah, the hands have to come in contact with it. No need, it will already become sour actually. It will become sour in 3-4 days. It's good to consume. So idli dosa appam, what happens is the idli dosa appam, the bacteria dies when we cook. Still beneficial, but not live bacteria. This is, Pickle usually contains a lot of salt and oil. So that is the issue, the pickle. But in Kerala, we make some vegetables in the salt, in the brine water. That is good. Green chilies, amla, nelika. So we'll just bottle it because it can go a little more watery. Can somebody help me with this? Kimchi is made in shorter duration, and you use Napa cabbage, that is the Chinese cabbage kimchi, and it's quite spicy. Here it's your choice, you want to add? No, that is also no, just a lot of chili and salt in Chinese cabbage. Salt, the non-iodized salt, iodized salt. So you can see some water has come out already.
So we can just put this over top?
No, it's come out on its own.
So she's
Okay, after this only. No, but then...
It draws the water from the vegetables.
You want to put your computer?
Then I'm happy to use this one.
No, keep it outside for 3 to 4 days in Kerala, but otherwise
Then they will use the Sligo
it will
first,
take a longer time in
and after we
colder
will use the
climates.
Sligo where they have a chance to respond.
So the recipe you can see, it is there on the screen.
When you make the tea, you have to cool it.
Cool it and then only add the SCOBY.
And the tea leaves or tea dust?
Tea leaves or tea dust, anything will do, you just need to strain it. So you have to press it down nicely. You have to pack it. There should be no air. And the water comes out on top. Rock salt, yes. Himalayan rock. Non-iodized salt also can be used. Crystal salt, both can be used. All the hard vegetables can be used. Yeah. Mangoes, when it's raw and hard, it can be used. Huh. Yeah, when it is hard. Yeah. Raw mangoes can be used. So it has to be pressed down tightly and the water comes on top. But like if you keep it, actually you can press some, you keep some weight or something on top so that, but by the time, like after a few hours, it will actually come, the water will disappear. But that's okay, in 3-4 days. 2 gram for 100 ml, 100 grams. Yeah, 2%. 2% to 5%. So, 2 grams. Yeah, 1/4 of a spoon. So you can cover it and just tie it with, and keep it in a cool, dry place, undisturbed. That's it. No, it should get, that should not be covered. No, you just need to like tie it with a thread or rubber band. No. because it should not be airtight because the bacteria has to thrive, no? Yeah, air has to enter. So you can add whatever spices you want. This is chili powder is there, so that is why it is slightly red in color. Chili powder you can put any spices you can put, like rosemary, thyme, mint leaves, these things you can. 1 kg of cabbage and 5 grams of 2% salt. So 1 kg would be like 10 grams of salt. Tender mangoes. Yeah. That is in brine. We are adding water and salt and then the vegetable. Come on its own. Okay. Yeah. Still it comes on. Yeah. It is. It's a similar thing. Yeah. This is 5 days old. Ready to eat. This will be served in the lunch time. We'll be serving this during the lunch. You can take around like a palm size serving. You can take. Every day. It's good to take every day. Probiotics like, yeah. No. You can have it.
Sorry to interrupt. We will have to wind up.
Then you can keep it in the fridge. This one for 15 days.
All right. I think the rest of the conversation can take place there. We will move on to the next session. That's something new. A new science has come in where we...
Not in power.
Please switch off that mic and then talk there. So, where we move from knowledge to how to implement knowledge. And this is where the science, otherwise called motivational science, comes in. How to motivate people who are not motivated. So, we will have a role play on motivational interviewing. This role play will be done by the experts in this field, the team from CMC Vellore. For your information, Christian Medical College Vellore is the only institution in the country which runs a lifestyle medicine course, structuring scientific information, structured course, 1 year of rigorous training. I have undergone that. I know how rigorous it is, and these are the experts who grill us and who have answer to all the questions in lifestyle medicine. So over to you, Professor Herb. He is Professor of Department of Lifestyle Medicine. He will introduce and tell us how we are going to do this. Over to you, Herb.
Thank you very much. So it's a pleasure being here to learn and to rub shoulders with each other. How many of you tell your patients to take on more lifestyle, use lifestyle as medicine, and your patients immediately do it, right? You tell them once, and it's done for life. No. This is one of our challenges. How do we motivate our patients? And how do we organize our clinical setting in that dimension? I'm going to invite Dr. Esther and Ms. Sangeeta to come up. And what we will do is we will try and give you 2 scenarios in the clinic. The first scenario is designed to be the classical presentation and the way we classically do things. I would like each of you to as they're coming up and we do these 2 scenarios, I'd like you to be thinking, what is right? What is not so right? And what should be done differently and better? In this first episode, I would like you immediately afterwards to let us know what you thought was not right. All right? Let's begin.
Next patient. What's your name? What's your name?
I'm Sangeeta, ma'am.
Oh, Sangeeta. Okay. Okay. Why are you here to the clinic today? To the lifestyle medicine clinic? Why have you come today?
I want to reduce weight, ma'am.
Okay. What's
I'm
your
putting
main
on weight.
problem? What's your main problem?
I'm putting on weight.
Oh, you're putting on so much weight.
Yes,
Okay.
ma'am.
Okay.
I want to reduce weight.
Okay. Okay. So, so how much weight have you put on?
20 kgs, ma'am, last 1 year.
That's quite a lot in 1 year. Okay. Okay. So, where do you work? What do you do?
I'm doing a BCom, ma'am. I did a BCom. I'm
Sure,
doing
sure.
a accountant in private company.
Okay, okay. So you must be eating a lot from shops and outside,
Yes,
isn't
ma'am.
it?
There is, unfortunately, I'm eating like that.
Okay, okay, okay. That's fine. How many times do you eat outside?
Ma'am, actually, on a regularly I'm eating out.
Maybe
Because
once a week or twice a week
daily,
or more than that?
Daily.
Oh, daily.
Unfortunately.
That is the problem. Yeah, yeah. Daily. You eat outside every day, is it? Okay.
Yes, ma'am.
Every day you're eating outside. Okay, that's one issue. Do you exercise how many times a day? How many times in a week? Nothing? Okay.
No, ma'am.
Nothing at all?
No, ma'am.
Okay,
I don't
okay.
have time also.
No exercise at all. Okay, that's another problem. Okay, so you wanted to lose weight.
Yes.
So here's what I'll tell you to do. Okay, I am telling you that the reason for you to gain weight is because you're eating out almost every day and you're not exercising at all. Okay, you do one thing. Just stop eating out at all. Okay, all 3 meals you eat cooked meals at home. Okay.
That is,
And
I can't, ma'am, actually.
you want to
I'm
lose
staying
weight or not?
I want to lose.
Okay. So you need to understand what I'm trying to tell you. Okay?
Yes, ma'am.
I'm the doctor. You better listen to me. Okay?
Okay.
You can't start an argument over here. Okay? So first thing, stop eating outside. Okay? Every meal cooked at home. All right?
I'll try, ma'am.
Okay. No trying. You have to do it. Okay?
Okay, ma'am.
You can do it. Okay? You have to do it. And exercise. Okay? 45 minutes a day. Okay, nothing less than that. 45 minutes a day, every day of the week. Okay, do these 2 things every day of the week. Meet me in maybe 1 or 2 months. You need to come at least once a month. Okay, 1 month later I'll see you. Your weight now is 80 kgs. Bring it down, maybe 75 kgs. Okay, that's a small target I'm giving you. You should be able to reach it. Okay. Okay, see you in 1 month. Okay, you can book the appointment and go.
Okay, ma'am.
All right. Would you say that was a typical clinic visit? Anything that you saw that was wrong? Shout out. Confrontational. Okay? Orders versus counseling. Not listening to the patient. Not empathetic. Blaming, not practical. The target is set by the clinician. Okay? All right? Good. I'm going to invite them to shift their clinic. It's often hard to be fixated in our old ways. We get into ruts. So now we'll have them change clinic visit or venue, and we'll have them try again. And this time, tell us what you think is right.
Sangeeta, you're the next patient. Please come. Please be seated.
Thank you, ma'am. Thank you, ma'am.
Yes, Sangeeta. What brings you here today?
I'm sorry, ma'am. I'm putting on weight, ma'am. I don't know why I'm so putting on weight past 1 year.
Oh, is it?
Yes,
okay. So, what was the main concern over this time period that you chose to come here today?
I think past 1 year my lifestyle is very changed. I don't know why. I'm eating out. I'm thinking about myself. Suddenly I got giddiness. I want to change my lifestyle, ma'am.
Okay, it's been a tough year, isn't it? Tell me about the past 1 year. What happened?
I have joined new job, ma'am. It was very tough. I woke up by 5 or 6. I'm starting my job by 9. It's end up by 8. And there is no time for myself or my family also. And I'm going out my friends. And thank you for asking this. And there is no time for me, ma'am.
Okay.
My lifestyle's totally changed.
Has been a quite busy year, isn't it? And a tough one for you.
Yes, ma'am. I'm so
Okay.
stressful. My life is so stressful.
Okay, what happened suddenly that you came to a lifestyle clinic today? What exactly happened? Anything in
This-
particular?
Yes, ma'am. Because I'm putting on weight, I don't think about to lose weight. But suddenly I got up with a giddiness. At that time, I checked with my BP, it shoot up. I was very wonder like how to rectify this. Then I tried many diets, any different kinds of treatment. It doesn't work for me, ma'am. That's why I came to meet you.
How do you think is your blood pressure related to your weight gain? You think it's
I
connected?
come across with by the social media. It's a huge content is there. I'm not sure about that. I was tried many things. I didn't get any result for me, ma'am.
Okay, so you do feel that your blood pressure has gone up because you have gained weight over the past year and you have been quite busy. Is that
I think
right?
so, ma'am.
Okay, okay. So, what do you think you could possibly do with your day-to-day life? Like, what changes you think you could possibly make, looking back?
I have to reduce my stress, ma'am. Then it may change my happiness. I mean, it may come good thing for me.
Okay.
First thing, I want to reduce my stress, ma'am.
Okay.
And I want to lose weight also.
Okay, stress. Okay. What about your food habits and exercise and anything that you think you could modify a bit?
I wanted to take a healthy food, but I don't get it. I didn't get it also because I'm staying in PG. There is no food. I'm waking late. I mean, waking early, but going to the work for early. And there is no time for me to eat breakfast. I'm eating some snacks at 10 o'clock like that. And eating lunch hurry like that. And my job ends by after 8 or 9. After that, there is I have a friends. They are calling me for the night dinner. I'm going to eat night dinner on a daily basis. There is no time to restrict, ma'am, this thing, because my friends also very important to me. Yeah.
Sure, that's right. So, any of these things you think can change a little bit with some, some bit of modification which you think could help you with your health? Anything in particular you think you could do it?
Yes, ma'am.
What do you think would be possible?
Nowadays, I'm not doing any exercise. I can try.
You can try.
Yeah, I want to
okay.
do.
What would you like to do and how do you think you could do that?
I can start with the minimal because no time. I can start, but I want to know how to do it.
Okay, okay. Sure. Maybe I will just note down some things which you think you can do. Just for my notes, let me just write it down. So you think, you said you go and eat out with your friends. You think you could do anything to cut down on the number of times that you eat late night outside with your friends? Is that a possible thing?
I can try, ma'am, definitely.
Okay.
If it's not good, definitely I will.
Okay. How confident do you think you could do that?
Out of 10, it might be 8.
Okay. What would make it a 10 on 10?
Not sure, ma'am.
Okay. When do you usually go out and take food from restaurants?
Daily after 10.
Okay. So is that after working hours?
Yes, ma'am.
Do you also go on weekends and do you go by yourself to the restaurants at late night? So maybe with friends you would find it difficult to avoid. Maybe on weekends, would that be a 10 on 10 to not reach a restaurant on weekends? Would that be a 10 on 10 for you?
Of course, ma'am, because that is my time. I can make it.
Maybe shall we say, I would note down that on weekends you would avoid eating from restaurants. Shall we try that?
Sure, ma'am.
Okay, and you did want to do exercise. How do you think you would be able to do that? About the time and how long you will do, how many days, where will you do, anything that you think is possible for you and doable for you?
If you give me some idea for me, some prescription, that I would follow, ma'am.
Okay. Okay. How much do you exercise now?
Not at all, ma'am.
Not at all. Okay. So let's start with simple steps. How far do you stay from your office and how far is it?
It will take some 10 to 15 minutes from my home.
Maybe once a way if you can take a walk or cycle instead of taking your bus or car, that is a doable thing.
Let me try first.
Try?
ma'am.
Sure. I'll leave that to you. Some attempts on that you could try. And you could tell me what worked for you and what didn't work for you. So we'll take one step at a time and we are together in this journey. All right? So when do you think you will have time next to come and visit me or drop in so that we can have a chat?
Can I come by next week, ma'am?
Yes, of course you could come. Which day would that be possible for you to come?
Yes, ma'am.
Which day could you come?
Which day? By Friday?
Sure, I'll just note it down. Friday, what time would you be able to come?
By 11?
11, sure. All right, we'll meet you on Friday, 11 a.m. Sure? Okay. Remember, we are together in this journey. One small step at a time goes a long way.
Thank you so much for hearing from me, ma'am. Thank
Welcome.
you.
Welcome, Sangeeta.
Thank
See you
you.
next week.
Thank you very much. What did they do right? Listening. Okay.
Open-ended questions.
Okay.
Open-ended questions.
Very good.
Affirmations.
Affirmations.
Yeah.
Good.
And reflective listening.
And reflective listening. Super. So the patient was in charge, or patient was controlling, and it was a collaboration. Okay? Anything else?
Patient was also happy at the end of the session.
Patient was happy at the end of the session. Okay? Okay? It was personalized, trying to see where the patient was agreeable. We use the word convenience.
And the goals set were more realistic, like, within she's working, so she will do the exercise in the weekend. She will not eat out in the weekend, It was more realistic to her real life situation.
Very good. More realistic to her situation. It was personalized.
Did not make her feel guilt.
And they didn't make her feel guilty. All right? Any other comments? Go ahead. She was engaged. The patient was engaged.
The physician was engaged with the patient, and the patient felt heard. The physician was engaged with the patient the whole time, and the patient felt heard. She was heard well, and that gave her the satisfaction at the end of the consultation.
Good. The patient was felt heard. One last one. There was eye contact, and the doctor was very much engaged there. Good.
Active listening and assertive communication, both together.
Active listening and communication both together.
Assertive communication, because they communicated with an emotional touch.
Okay. Good. Now, if I can have our
next Friday, 11 p.m. was made certain. The time was fixed. For the next appointment, the time was fixed so that she could, plan ahead.
Now tell me, how much longer did the second encounter take than the first one? Less? Same? More? How many say it was about the same amount of time? How many say it was a little bit longer? How many would say it was a lot longer? Double. Okay? All right. It was still fairly short, though. Very good. Okay. Last comment. Last question. Great. If I can invite our audiovisual people to switch to the slide, it has already been alluded to here in motivational interviewing. What we try and do is we try and use the acronym ORS darn cat. And with ORS, it demonstrates our typical skills as we get started with motivational interviewing. And these are, as has already been mentioned, open-ended questions, affirmations, reflections, and summary statements. And we try to develop change talk, and with change talk we think of darn as we prepare for that. And darn is simply desire. Is there a desire to change? Does a person feel like they have the ability to change? What is the person's reasons for wanting to change? Unless the person has a reason, it'll be much more harder to change. It's easy for us as physicians to tell other people what to do, but to have somebody actually do it, they often need to have a very good reason. And then, what is their need to change? And as part of that, we often ask them, how important is this change to you on a scale of 0 to 10? And then that's followed up with, how confident are you that you will be able to make this change? And what they say is that if the score is at least 8 over 10 for both questions, there's a good chance if it's for that particular change. If it's less than that, there may need to be more work done. And then finally, in implementing the change talk, is the patient giving some kind of commitment? How are they activating what they want to do? And what will be their next step? So this is something that, for all of us, takes time and practice. It takes more than just the 2 minutes or 10 minutes total that we have for this interaction here. But if we can think more, how can we use and apply ORS, darn cat, in motivational interviewing? There's more, but this here is a great basics and a way to begin. Thank you very much.
Thank you, sir. Now we move on to the session 4. I invite the chairpersons to come upon the dais. Dr. Somashekar Nimbalkar, Professor and Head, Department of Neonatology, Guj. He is the President-elect 2026 NNF India. I welcome you, sir. Dr. Amit Upadhyay, Pediatrician and Neonatologist, Secretary General, NNF. I welcome you, sir. Next is Dr. Dinesh Tomar, Consultant, Asta Hospital, Rohtak. I invite all the three to chair the session. Now we have the topic, Birth of Lifestyle Medicine, a New Era in Healthcare, by Professor Samuel George Hansduk, Professor and Head, Department of Medicine, CMC, Vellore. I invite Professor Samuel George Hansduk to the dais to speak upon the topic. Over to you, sir.
It's still morning. I'm sure we are standing between this presentation and the lunch. And Dr. Manoj has said he's very strict. He will only give lunch to after the sessions are over. We are a little going behind time. We'll try to go quickly. My work is easy because most of our previous speakers have talked. I think by this time all of you guys must be saturated with lifestyle medicine and the different pillars of lifestyle. I'll just try to give a little different perspective to lifestyle as we talk about it as a new era of healthcare. I need to acknowledge getting into KOCHI, this beautiful city, God's own place, is something that has really excited us, and we are really relaxing and enjoying here. Many of these have been covered in different ways. I won't be repeating it. We'll just try to give you a perspective as how do we look at lifestyle and how do we practice lifestyle. We know our NCD is going up, the cardiovascular being high up there. Most importantly, we know the various risk factors. I don't have to repeat that, from diet to activity to stress. Air pollution is also coming up, something for us to know. Alcohol and tobacco we have known. This is one thing I just wanted to share. We shut down the entire world because of COVID. Do you know how many people died because of COVID? If you put it all together, roughly about 7 million. And if you look at the death because of heart disease per year, it's 17 million. 17 million death every year. And if you take it for 3 years, you can calculate what numbers comes. COVID was just about 7 million death over the 3 years time. But imagine you have shut down the whole world for COVID. Not a single KFC, McDonald's or anything was shut down because of 17 million death every year. Something to think about. Now, this is something that we have all known. I want you to keep a watch on the year. This is 1948 when this definition of health was given to us. And what is the unique thing about this? And here I want to talk about the paradigm shift. From medical to health, from a single organ to the whole person, from a symptom to the root cause, and from disease to well-being, treating disease to well-being. And I'll just quickly try to highlight it. The paradigm shift one talks about, this is where I did my studies, All India Institute of Medical Sciences. Watch the word medical sciences, 84 to 94. I then shifted to a medical college in Nepal, and this was called BP Korala Institute of Health Sciences. Health Sciences. 2000 I joined CMC, and very interesting, the Department of Pediatrics here is called Child Health, Psychiatry is called Mental Health, and Community Medicine is called Community Health. Just a change in the word, medical to health, completely changes the way we look at a patient. Not at the disease, not as high sugars that has to be brought on, but as a person in whole. Paradigm 2 is where we are moving from an organ-based system. Medicine has really kind of developed over a period of time. We are specializing and super specializing, and super specializing. It's time to get back to see the holistic picture. If some of you remember what Robbins' textbook of pathologists said, do not come so close to the tree that you lose sight of the forest. And it makes sense. Here there's a weight gain over there, but then why is that weight gain over that period of time? Most of the time, neither we are taught, neither we practice in our daily. Very interestingly, the American College came with these 6 pillars of health. I wouldn't repeat, most of you would know that. And very interestingly, the American Heart Association, American lifestyle is anyway committed to lifestyle, this is obvious, but American Heart Association in 2010 came up with what is called Life Simple 7, and that was upgraded 2022 to Life Essential 8. Sleep was added over there. All those same pillars. Very interesting to see it's coming in the mainline societies. So we are essentially talking about equilibrium, and this is nothing new. It has been there age old. The Chinese yin yang, the Ayurveda, Pitta, Kapha, the Greek medicines, all of them talked about balance, but somewhere down the line that we have lost it. The paradigm shift 3 talks about shifting from treating symptoms to treating the root cause. Now, let me ask you something. If a patient with malaria came, what would you treat that patient with? Most of you will say chloroquine, right? I say, why don't you treat the patient with paracetamol? The patient came with fever, so you give them paracetamol. What would be your response be? The fever may come after 4 hours, so I say give another paracetamol after 4 hours. But how long to give it? 4 hourly for lifetime treatment of malaria. new treatment. Does it sound fantastic? I don't see that expression on your face, but that's how we are treating every disease, be it diabetes, be it hypertension, be it dyslipidemia, be it rheumatoid arthritis, be it cancer. Now we have wonderful drugs in cancer coming out, target cell therapies. How long do you give them? No, it's not so toxic. It's lifelong, as long as you live. Does it really sink to our mind how has our medicines really been evolving? Right? So the paradigm shift 4 is when we talk from treatment to remission or reversal. We needed our surgical colleagues to teach us how to treat diabetes, right? Medicine fellows didn't know how to treat diabetes. Surgeons came and taught us, you guys, you're treating diabetes. We are eliminating diabetes. The first time the word remission came from our surgical colleagues to say, guys, poor fellows, let us teach you some medicine. So bariatric surgery came, and then you look at the results. 80% remission. You stop medicines, right? 1995 study, 2004, second year 72%. Of course, by 10th year it started coming down. But you look at the Stampede studies, 75, 62, 51% at the end of second, 6th and 12 years. Pretty impressive. Look at lifestyle, 11.5%. 2014 direct study, about 46%. The last one with a small sample size number of 20, 70%. Sounds impressive, but somebody will say, but that's 20 people. But the concept here is, really, can you stop medicine for diabetes? My doctor said you have to take it for lifelong. So here we are talking about a paradigm 4 shift from treatment to cure. And very reluctantly, the American Diabetic Association finally agreed to use the term diabetes remission, and then you can see the various definitions of remission was put on by the ADA. We saw this. You see, what was historic about this study was we never thought or imagined that a process like atherosclerosis, which sounded like a permanent pathological process, can actually be reversed. And I think the key thing that Dr. Dean Ornish and Calvin Lesson showed, that even atherosclerosis is reversible if you give it. And very interesting, in his lifestyle heart studies, the people on the standard treatment, the obstruction continued to increase. It's just that it was a little slowed down with the medicines, but it never reversed. The only thing that reversed it was the lifestyle changes. Now, Dr. Esther has already talked about, you can see 1948, just look at the date, 1948, the WHO definitions and the Framingham came at 1948. But even before that, 1938, the Harvard talked about adult development among their sophomores and graduates, which was done over a long period of time, 85 years, following up to see what happens to their mental development. And following that, we have almost major institutions doing a cohort studies, and I think the writing on the wall is very clear to say, does it work? We have very good enough evidence to say it does work. So going back to our definitions of WHO, there are two concepts I just wanted to touch. Concept number 1 is, as we age, we get disease, which we have accepted is a part of aging. And we live for, say, 60, 70, 80 years, we call it as lifespan. Lifestyle medicine is trying to switch from lifespan to health span. The days that we can be healthy as long as we live is the key areas that we are trying to look at. And so just want to introduce this term health span, many of you have heard. And concept number 2 is to see the approach of medicines. Unfortunately or fortunately, we have borrowed it from the industries. They talk about industry revolutions 1.2, 2.2. Initially, we had steam engines, then we had electricity that came up, then we had electronics and little automations and digitalizations, and now we are talking about 4.2, talks about smart technologies, cloud computing, big data, networking, machines, processes. Something similar has also come up in medicine. We had physician-centered manual records. I don't know how many of you still write patients' details on your cards. I'm sure many of you would be. Some of your centers have gone into electronic medical records. Trouble is typing. Slowly that is moving on to electronic records, wearable devices, telemedicines, and then we are looking at AI. Can AI take your history of your patients? Can AI make a diagnosis with all those histories and examinations and investigations? Can AI actually treat your patients? Something to ask. We will vehemently say no and we should not allow it, but reluctantly it's going to happen. So what is Medicine 4.0? The concept is, and what everybody is talking about, is a personalized medicines. That you evaluate your patients holistically, and that's where the holistic concept comes in. You analyze these data and giving all the evidences that you have in your mind, the system can itself make clinical decisions. We are almost moving in that direction. All that we need is predictive, and with the large data you can predict what is going to happen. Now we have got Framingham Heart Risk Scores, Indian Diabetic Risk Scores, all those are predictive models when your things are right. And then we are also moving towards monitoring. Monitoring using wearable devices and telemedicine. So Medicine 4.0 is really moving us towards that level. But the key thing I want you all to see over here is the holistic is one thing that is coming up, and we are really looking at how can we reverse disease. So if I have to redefine health, I would say health is when these various pillars of health are in equilibrium. So if health is an equilibrium, what should be the disease? Very simple. It will be a disequilibrium. So a disequilibrium in the pillars will cause disease. So what should be the healing process? The healing process should be bringing back the equilibrium. But just look at this slide. Everybody blames it on gene. Why do you have diabetes? Because my father had diabetes. Everything is okay with me. The problem is the father. I wish I didn't have that father, or I had a choice to choose my father. I wouldn't have diabetes, but then we can keep going on. Gene has a very smallest contribution. Environment plays a role bigger than the gene, but the biggest thing is lifestyle. So if that is so, how do we? Healing really then means restoring back the disequilibrium. What essentially I want to bring it over here, this is not easy. Let us not practice lifestyle as a prescriptive medicines, which sometimes we try to do. Sometimes you say, oh, they gave me I'm a vegan, you gave me some milk product, and please tell me what you're serving and all. Sometimes we become very judgmental and hit the lifestyle pillars. The pillars are pretty hard, and we hit them very hard. No oil, no salt, no sugars. I don't eat that, I don't do that. I am a very sane things. Healing is a complex process. You have to change the cell factors. You have to also address the environmental factors. The issue is we don't have time. You saw the interview, the moment you start asking the right question, it takes time. And then I'm just going to hint on what is a transcendence factor. These are the steps of behavioral change. Many of you know that. Look at the relapse rate. Exercise adherence, within a year's time, 50% goes down. Healthy eating, 70% relapse. Weight loss, 80% get back the same weight. Smoking cessation, almost 90%. Continue to smoke at the end of 1 year. We have a terrible relapse rate. How do we address that? So what are we doing? Really, how do we approach? We need to do an evaluation. We should be holistic. We need to assess the preparedness. Some of those things you saw through the MI. We are planning our lifestyle interventions, monitoring, and finally, and I will highlight over here, the key thing is if you can convert your patient as health ambassadors. If a person is able to stop the medicines for diabetes, you always have a fear, will he relapse back? How to prevent relapse? Tell him, please catch hold of 10 other diabetics and give him the same advice to them. And if he does that, and those 10 people are looking up to him, very less chances that he will slip back because their compliance is not dependent on him. Smart move, right? So it's very important. The history, I won't go into the details. Holistic evaluations is the core or the foundations of your lifestyle practice. And I've just given you the headings.
You have 5 more minutes left, sir. Thank you.
And so you have this background that you have, and there are different questionnaires. You can choose which one you would like to do, and this will give you a baseline evaluation of a person's. These are some of the examinations that we do. Anthropometric does become our main things. Fitness, there are different domains that you need to look into. And investigations, I'm just giving you this slide. Somebody who can afford, we met in the Longevity India conference in IIC, they said, we do a baseline evaluations for CEOs of companies. It costs us 1 lakh rupees for baseline evaluations. Where does that money go? Microbiome, genomics, the entire things, all those things are expensive. They can exactly tell you what are your chances of developing what disease, when it will happen, and all those things. So if you want to go high, it can go, but there are basic things that you can do. And these are some of the investigations. I'm not stopping here. Most of these things you would know, just to complete the list. And then once you make a diagnosis, disease list is just one part of it. But the key thing is evaluating them on different pillars of lifestyle is what is key, because that's where your intervention will come. And then your advice will anchor on the root cause analysis. If you think his diet is a major issue, let's start off our conversations over there and build it up. Assess the preparedness, help them to put SMART goals, coaching, monitoring. We just have covered that. But let me finish with this slide. Why do people do what they do? Do we ever ask them? Nobody likes doing what is not right, but still they do it. Ask a smoker, does he know what smoking can cause? You have enough packets and cancers and the picture of cancer but he still smokes. Understanding a person who he or she is, how they have developed their spirituality. Spirituality, I call it as a worldview. All of us, we have a worldview, the way we look at life. Understanding that, empathizing with that, finding out why they should make a change, and making a commitment to that, to travel along with them, to reach a level of health, is the final thing that you may need to do. So transcendence is also very important, and without that, I don't think so you can really practice medicine. We've been taught medicines, but we haven't been taught life. And how do we understand life, and how do we impact lives? And if you don't know that, and if you don't connect with the patients, simple lifestyle prescriptions, in my mind, would really not work. So with these words, I will stop here. Thank you so much.
Thank you, sir, for the wonderful session. We have one more session. Beating Malignancies with Lifestyle Choices, a Cancer Prevention Blueprint by Professor Dr. V.P. Gangadharan, Senior Consultant and HOD of Medical and Pediatric Oncology, Lakeshore Hospital. I invite Professor Dr. P.V. Gangadharan, sir, for taking the session. Over to you, sir.
Good morning to you all. For a change, I am not P.V. Gangadharan, I am VP Gangadharan. Okay. I think this mistake happens wherever I go, because I always address somebody who is much more better known to me, known to people. I think that's P.V. Gangadharan. But I am VP Gangadharan. I think I'll try to confine my topic to purely my area of work. I'm basically a medical oncologist. And my area will be purely confined to malignancy. With some basics, I think I'll start. When we speak about, I think malignancy, I think as a base, you should know about the three major genes which are involved. The proto-oncogenes, whose overactivity is the cause for cancer, or the tumor suppressor genes, they are not there. The suppressive activities of the tumor is gone, so there is a high chance for them developing for a malignancy. And that's a policeman. He's a genomic stability genes, and if he is stable, he'll try to modify things and try to correct these things. So these are the three basic genes which are involved in malignancy. And the cancer is basically become a play of these three genes. That means an overactivation of the proto-oncogenes, or a suppression, inactivation of tumor suppressor genes, or an inactivation of the genomic stability genes. So you are basically, the cancer as such, if you say, it's basically a mutation of any one of this. Whatever cause you put it across, it will be like the recent maybe an activation of the protogenes, or it can be an inactivation. If you tell that's the risk factors that are going to be the reasons. I think we will always say starting with aging, because as the age advances, the chance of pregnancy is high in that population. And come to this other end, radiation, some of the chemicals, the infections, but concentrate on the major part, that is your lifestyle. So the topic will be like lifestyle and its influence on malignancy. And whenever you speak, you see that, the majority, I think the last speaker was also mentioning that genetic causes form only hardly 5 to 10%. And all the rest are external factors, including your lifestyle. And if it is the population as a whole, hardly 0.3% are inherited and coming with a gene which is responsible for a malignancy. And they cause less than 5 to 10%. So it cannot be called as a hereditary disorder. So it comes your lifestyle, your environment, and of course I told you it's only 0.5 to 10% of the families. And come back to our country and see what is the statistics like. There are about 15 lakhs of new cases detected every year as a new case. And if you come back to Kerala, see, every day is 120 plus new cases every day. And it's again on the increase as a whole. And these are the major cancers in the country, if you say. In males, the two major cancers are the lung cancer and the head and neck cancers. And if you come back to females, every third female who walks into the OPD with a cancer is coming with a breast cancer. And the second commonest is cervical, but fastly catching up are the ovarian tumors. Maybe 10 years from now, the second commonest in females is going to be an ovarian cancer and not cervical cancers. I think this has to be in your mind, because when I'm going to speak the rest of things like how are you going to prevent it and all, I think this statistic becomes very important. And we got certain cancers which are on the increase in the country, like the colorectal cancers are on the increase, the male's prostate cancer is on the increase, liver cancers are on the increase, and in some areas, thyroid cancers are also on the increase. So that is statistics of what's happening in our country now. How are you going to prevent it? The next question. And they are all cancers which can be prevented by various modifications. Lung, breast, cervix, colon cancers, oral and liver cancers. So there is a policy like, there's an action for cancer control called National Cancer Control Program. Concentrating on your lifestyles, majority like tobacco, your dietary habits plus exercise and alcohol. These are the major steps which are being taken into action for the National Control Program. We'll come to one by one. Come to smoking and chewing tobacco. This is account. In cancer deaths, almost 1/3, 30% of deaths are associated with the use of tobacco. And its health implications again you can see in various forms. If you are smoking, you have got more probability of lung cancer. If you are chewing, then you have got a probability of head and neck cancers, like that. And it's a real staring statistics of our country. Like 8 lakhs people are killed because of tobacco products. And 12 million people are getting sick because of tobacco every year. And there are some hard facts when I speak about tobacco. Like 4,000 chemicals, out of which 400 of them are toxic. Just think of 400 toxic chemicals being inhaled. Like they're all, big problem for you. And every minute you smoke, or every cigarette you smoke, brings down your life by about 11 minutes. So probably you may not count much, because every cigarette brings your life by about 11 minutes. And you can see this. 90% of the lung cancer deaths, they are directly because of the use of tobacco. Hardly 10% is non-smokers. And if you take the 10%, out of that about 10 to 15% are passive smokers. So whenever you speak about lifestyle, you'll have to again concentrate and go and tell that if you smoke, the risk is going to be this much, and if you are using chewing, then that also. To say that 6 million people die every year because of passive smoking, not because of active smoking, passive smoking. Hence, the major concern comes is because about 1/3 deaths are directly and 0.7% because of passive smoking. And the risks are again higher as you change from your smoking habits. If you are going to go for tobacco or chewing, then the site of cancer varies, that's all. And lot of topographic variation, how you smoke, how much amount you smoke, how long you smoke. There are the topographic things which you have to think along with this. This is staring at you again, because if we speak about the commonest cancer in males in our country, lung cancer, the only way is to prevent it. You don't have a screening program, an active screening program for an early detection. So if you have to fight against lung cancer, the only option is that you have to think of stopping smoking. And it goes on, and the major tobacco cancer are all this. Major causes there are directly linked with the use of tobacco. Then you have got some of the cancers where they are a contributory factor along with other factors. To say that if somebody has to speak about lifestyle changes and cancer, in the first 10 steps are going to be against tobacco in any form. Come to my second point. Alcohol. I think some of you are not Keralites, and for them, they are the most disciplined crowd in the state are this queue only. That means who are waiting to get one bottle. They are the most disciplined crew in the state. And we can see the implications, like the first prize goes for cancer for the alcohol users, plus liver cirrhosis, plus psychiatric problems and all. And you can see that all these cancers are linked with the use of alcohol. Like all head and neck cancers, if they are also alcoholic, even the percentage of rise for them will increase tenfold if they are smoking plus alcohol. And you can see the breast cancers, the bowel, liver, everything. I think the breast cancer, they are, one of the contributory factors is going to be use of alcohol. Big list. Alcohol-linked cancers, again big list are there, like head and neck cancers, increasing by tenfold if you are smoking along with that. Then esophagus, stomach, colorectal, liver, breast. To say that, you have to say no to cheers. There's no other way, no to cheers. So the major two parts are going to be your no tobacco, no alcohol. The next part comes, what should be your diet? The question is addressed in two ways, what you should not and what you should. I think the easy way to remember is, whatever you are eating now should not. And whatever you are eating years back, I think should be. I think that's the best way to remember this, but coming to it shortly. The diets they can act as initiators of malignancy, they can act as promoters, they can as well act as protectors, that is anti-promoters. And what are the factors which increase the risk of developing a malignancy? I think go fast. High fat, high calorie diet, high content of red meat, high temperatures. High temperatures can liberate HCA and polycyclic aromatic hydrocarbons which are dangerous, and a low vegetable consumption plus high alcohol. And you have got the fats which you divide. The good unsaturated fatty acids has to be part of your diet, which forms about 10% of your fat has to be with this. And it's going to be like nuts, seeds, fish and variety oils. They are going to be your good saturated fats. And on the other hand, you have got the bad fats. The saturated ones, the hydrogenated ones, and the trans fats, the most dangerous. And you can read from one end to the other end. Most of the things you are eating or you are eating every day or every week, I think that comes in the purview of your bad fat. So the problem comes when you are restricting for the fats, you have to definitely restrict on the bad fat, which should form only hardly less than 10% of the fat that you are taking. And your main thrust comes high fat, high calorie diet, lack of exercise, you are landing into trouble with obesity. Whatever NCDs you connect with, there will be obesity like. And the second mortality you can see, I said 1/3 of the cancer deaths are because of tobacco. The 20% is because of the obesity related cancers. Huge number it is. And there are all the cancers which are related with obesity like breast, colonic cancers, esophageal cancers, renal, pancreatic, uterine. They are all connected with your obesity. So your caption comes, fast food kills fast. That's the best caption you can ever imagine. Fast food kills fast because they contain high calories, high fat, high salt, and they'll end up you into trouble. And that is where we have to say that, that's why I started and telling that we have changed our dietary habits from what we were to what we are now. And all these are, I think, connected with this. And when you go back and see, why this obesity? I think it started your junk foods, what you are eating a lot. And the sedentary lifestyle. You have forgotten to go for an exercise. And the group of couch potatoes, where you make them, your children like couch potatoes, they go and sit in front of a TV or a tab, and you make them eat like this. I think the picturization is very correct. You are sitting in front of a TV and going on enjoying your food. You don't know what you are eating and how much you are eating, and you are going to be obese. So lifestyle change involves your routines as well to be changed along with what you are doing now. I think you have to say no to energy drinks. Again, because they contain high sugar, high fat, high coloring agents, high taste makers. I think that again becomes a problem for you in the long run. To say that the basic problem for obesity has to be prevented. And the question comes, how could obesity lead to cancer? Because the fat becomes a storage organ for your estrogen as you are growing up. And estrogen is a stimulant for breast cancer and uterine cancers. That's number one. Then there's a high amount of insulin being secreted as a growth factor which can stimulate malignancy. And third is cytokines are released from the macrophages which again can be a promoter of a malignancy. So definitely your baseline is going to be an obesity by whatever you are telling. So you have to prevent that in whichever way you are going to go ahead. And what you should do, the next question. There are certain cancer fighting foods. Okay. Basically what you want is, whatever negatives you tell about vegetables, green leafy vegetables, fruits, they are going to protective effect against malignancy. And the properties are different, but they are going to protective effect. And so it has to be part of your diet. And 4 or 5 cups of fruits. Much more important is that you want vitamins, you want minerals, but much more important are the phytochemicals and fibers. They are going to give you a protection against malignancy, and these are all phytochemicals. The beta carotene, lutein, lycopene, they are all part of your phytochemicals. And the diet which is going to give you are beans, berries, cruciferous veggies, dark green vegetables, tomato, whole grain, green tea, soya. They all give you enough and more of phytochemicals to protect or to fight against a malignancy. That should be a plan of action. And I told you regarding the temperatures, high temperatures, they can result in HCAs, which is going to be a carcinogenic for you. And the polycyclic aromatic hydrocarbons, they are also going to be a problem for you. So your cooking, way of cooking again is something which is very important when you are preparing a food. So the best plate for you to take food will be half of it filled with fruits and vegetables, 25% is grain of your choice, and 25% is going to be your protein of your choice. This is going to be an ideal plate for you to take the food. The question comes, what to eat and how to eat. I think that be given by the plate which I have already shown you now. So exercise properly, eating a healthy diet, maintaining a weight, avoiding smoking and liquor, and I think go for a screening programs. And specifically certain malignancies has to be taught in your process, like they are all preventable cancers. The list are preventable cancers, and For certain specific, like for a breast cancer, I think again the risk factors are going to be like this. There are going to be risk factors, and plus your change in lifestyle comes like your modifiable risk factors. No obesity, no alcohol, careful about female hormones, and the first childbirth before the age of 30 years, and breastfeeding. I think these are all changes which has to be in your mind when you're thinking about a breast cancer. And when you're speaking about the uterine cervical cancers, I think the major thrust will be on going to be a vaccinations against HPV vaccination. For a colorectal cancers, stop smoking, healthy diet, and maintaining a weight and screening programs. I think that's going to be your steps for a colorectal cancer. And for you can see that 50% of the colorectal cancers are preventable just by your lifestyle adjustments. So just remember, I think it's a major, huge number. About 50% you are going to prevent by your change in lifestyle. You have to plan that. And for a liver cancer as well, you can see the fatty liver going through various processes, coming to a cirrhosis, and 5% of them going for a malignancy. To say that, yes, you can modify your lifestyle and try to prevent cancers, and the prevention becomes 30% of the cancers are preventable. So that at the end of the day, just by no tobacco, no alcohol, changing your lifestyle, including exercise, I think if you are going to prevent 30% of the cancers, I think why don't you attempt? Something specific about Kerala. Because the population, aging population is going to be in Kerala more, so we have got a higher incidence of malignancy in the country. And lifestyle changes are again, alcohol on the increase, and tobacco again. I think so we have got a lot of problems which are facing, and as a result, the breast cancer incidence in Kerala is going to be very high. You can see this, the marriage change, and lack of breastfeeding, and dietary practices varies, and they all contribute to an increased breast cancer in Kerala. Now, to say that we have to change. We have to change. If you have to conquer this disease, I think prevention and early detection are the only ways, much important than your line of treatment. So the 10 steps, no tobacco, no alcohol, limit calories, stay lean, dietary, fat content to be, fibers high, and the various things to be eaten. There are 10 steps to prevent cancer, and that is going to be my thrust today, to say that cancer is a preventable disease, at least in 1/3 of the cases. Thank you for your patience.
Thank you, sir, for your session. I now request the chairpersons to open the house for discussion.
Thank you, Dr. Samuel and Dr. Gangadharan, for very elaborate talks and very interesting ones. I'll just, before we hand over to the audience, I think I can ask both of you all, we are promoting lifestyle modification. At what age should people start lifestyle modification?
I think they should start learning from the school days. I think the best time to teach them, at least to do it, I think will be the school days, because I already showed you, because the majority are going to be obese because of all these problems, with all the problems coming up. Like if you say the Indian statistics, there's a 2.5 times higher incidence of hypertension, BP in the pediatric age group. And if you see them in the long run, there are 8.5 times higher risk in this obesity group for the hypertension. Very high incidence of diabetes mellitus in the state. So I think it has to be started from the school days.
Maybe lifestyle modification should begin from birth, from exclusive breastfeeding. And we read in Robbins that seeds of obesity in adulthood are sown in infancy itself. So if as a 1-year-old you are obese, then you are more likely to be obese as an adult as well. So sir said role of genes is important as well, but it is not the most important factor. I read a WhatsApp message which said that obesity runs in my family, when in fact it is nobody runs in my family. So often we blame it to the genes, but it is a collective lifestyle of a family, so that everybody in the family becomes obese.
Questions from the audience?
Dr. Gangadharan, in the morning there was a discussion about dairy and breast cancer. Can you speak about your experience? Dairy products and breast cancer.
I think the hallmark I already told you is the dairy products, they become part of your saturated fatty acids. And majority of them are the transformed fatty acid group. And the end result is going to be obesity. So I think that basically whatever you are saying as no is something which can, if you are continuing, is the basic hallmark is going to be obesity and a hyperestrogenism. And that is the hallmark to say that they have got a higher propensity for a breast cancer as well as for a uterine cancers. So just like I was very specifically saying, the genetic factors are operating only a very small percentage, very, very small percentage. Like 0.3% is going to be your genetic tendency for all this. For a breast cancer, you said the tendency is going to be 5 to 10% for a chance. But that chance is going to be made you mean close to 100% if you are going to go for all the provocating factors or the precipitating factors. That is why we say that when you are, say now as a routine process, whenever a patient comes, especially younger females or a family history, you go for a genetic screening. They go for genetic screening and you try to identify the genes which are involved, like the BRCA1, BRCA2 and all. And you screen the whole family, but the message given to the family is all, your chance of getting the disease has to be prevented. So I think that thrust comes even now to say that your lifestyle has to be changed even in the family members, much more ahead that you are a part of the family.
Ramarao, your question.
Sir, this is Dr. Ramarao from Vijayawada. Thanks for your excellent talk, sir, and Prof. Samuel George and Prof. Gangadharan. And this is about this is a question to Prof. Samuel George. This is about the spiritual health. We talked about physical health, mental health, and also social health. What about this spiritual health, sir? How important it is? Can you just comment on that, and then can you just share your experience, sir? Thank you.
Thanks for that question. It's a very long answer, but there are different ways to define spirituality. The simplest way that I put it is a worldview that we all develop. It could be from the religious background, the faith background, or even atheists can have values, moral, something that we conjure over a period of time, which determines the choices that we make, which determines the peace that I have, which determines how I interact with others. If you look at all the studies, there's one single factor which has the biggest impact on longevity is social connectedness. Very interesting. It's not diet, it's not all. The highest is social connectedness, and that's where we have problems. No? I mean, getting along with one fellow who's not trying to behave himself is so difficult, right? And that to understand that person and to figure out how to interact with them requires a deeper maturity within yourselves, which we can call it as spirituality, and that would be one single factor which determines your social connectedness, which determines your health and longevity. So it's philosophical in the sense, but there are a lot of scientific studies on that. The first study that I quoted, Harvard, also looks into that same factor, and they found that the social connectedness has a major impact on the longevity.
Sir, your question.
It's a very useful talk now. My question is about how often should we do the PSI to prevent the prostatic cancer? The second question is, does the responsible drinking causes the cancer? PSI, how often?
Regarding PSI, there are a lot of fallacies. One is the false positivity which comes. Even if there is a prostatitis or even if there is some urinary retention, the PSI can be high. So the value of PSI as a screening program is being questioned by a lot of people. Okay, whether it is about to do that. But the basic concept is, above the age of 50 years, you have to go for an annual PSA examination. But your PSA is found to be high. Say you are doing it once, then it's found to be high. Then you have to repeat it after about 6 to 8 weeks. and see it's rising. Only if it is going on rising, then it is significant. So that means a serial monitoring is the only way to see, but a single value may not be enough for you. But as a routine, if your PSA is going to be normal, I think do it only once in a year.
My second question.
Pardon?
Can you ask the question again?
You have the limit of the responsible drinking limit is there, no? 1 to 2 peg for the male and 1 peg for the ladies. No, there is a dictum like that. Does that cause the cancer? No.
Pardon?
Responsible drinking.
It's about the responsible drinking. There is a statutory warning. No, the men are allowed 2 pegs per day and the ladies allowed 1 peg per day. Does it cause is this a cause for the cancer? No.
Yeah, I got it, because I am not able to hear it properly. The cutoff is only for a cardiologist, not for an oncologist. So oncologist never gives a cutoff value for your alcohol. It's 0. But for a cardiologist, they say that taking a little bit, maybe a little bit can stimulate the heart, but you can take a decision whether you want to die of a cancer or want to live with a cardiology problem.
Sir, I would like to ask to Dr. Gangadharan, sir. Actually, sir had mentioned about avoiding supplementation to prevent cancer. In the view of wellness clinics coming up, giving glutathione antioxidants, what is your opinion about it?
No, what I meant was, see, whatever food you were taking before, okay, that's enough for you to say that you have got enough of antioxidants and all these protectors. You need not have to supplement them, okay. And it has been shown that supplementation is not the answer for you. Because even if you are going to continue with your same lifestyle, and if you are going to say that I will eat say 1 gram of turmeric every day, it's not going to help you. So the way is you have to cut down your way of lifestyle to a better way of lifestyle. That's enough. And I think then only the problem comes. If you got something which is lacking, then you can supplement. So the supplementation with the same lifestyle is not the answer for you.
Sir, excellent talk by both the speakers. My question is to Dr. Gangadharan, sir. Sir, you spoke about we should go back to the olden days. So that means the cooking methods also should go back to the olden days. So can you throw a light on the current microwave cooking and the air fryers?
No, the microwave as such doesn't have a problem. Okay, it doesn't you have any etiology with malignancy. But I just went it through fast. Like if you are going to take it to a very high temperature, like in grilling, and much more important is like if you are grilling a fish or if you are going to grill, a fleshy piece, when you are turning it back, turning it aside, like turn this side or that side for frying, don't use a sharp needle or sharp thing and do it, because if you are going to make a hole in that, I think your problems are going to be coming with the polysaccharide garments outside. So you have to use a spatula or spoon and then turn. And high temperature again can result in heterocyclic amines. So to say that your temperature has to be lower side and the way of preparation. And microwaves doesn't have a problem as a whole to say that they are got any relation with malignancy.
So air fryers, the current trend is air fryers.
No, it doesn't have.
Vitamin D3 levels which we are monitoring so aggressively, is sun exposure better or regular intake of vitamin D3 is better? Will we get an increased risk of skin cancer?
I think it's always, no, we are happy to say that till this point of time. Forget about this year. This year I got, a lot of UV rays which are coming out this year. Your skin pigmentation gives you a protection from the skin cancers of our country. Okay, your dark pigmentation is your protective effect against skin cancer in our country. And that is why we say that you can have exposure to sun and then get enough number of D3 because of that. But supplementation is good enough. So that is why we have started checking now, because we have become more and more confined to cars and confined to your rooms, not going outside. So invariably the vitamin D is going to be low in our population now. So we had to supplement. That's, I think, good that you supplement, but check vitamin D and that, because hypervitamin is also a problem for you. So check vitamin D, and if it's low, supplement.
Thank you, sir.
Thank you. Dr. Samuel, I had a question. Lifestyle modification, as we see in the Western studies, mostly it is given to an individual. Western societies are generally individualistic, while Asian societies, India, etc., they are more family-oriented, social. So how possible it is for one person in a single family to change his lifestyle? And so most of the studies that are quoted are of people who have changed lifestyle and improved. Are there any studies which show that families have changed lifestyle, or the social structure or the village has changed lifestyle and health has improved? Are there any studies like that? Because that is what we need. Very difficult for individuals in India to change their own lifestyle. खाना कोई और बना रहा है, खा कोई और रहा है.
Not that I have come across any studies, but when you're looking at behavioral changes, we have kind of made it a habit that we call the entire family. More specifically the wife, so that because that is the one who cooks, the guys, they do the shopping, so put them both together. And then we also tell them that it's not, you are obese, you sit on that corner and eat that. Doesn't really work where everybody else is eating. So it is completely a family commitment that they make, and the way you motivate the other person, it says if you want the dad to be healthy and nothing to happen to him, you have to help him. That means you also need to do that. So social support is very, very critical in bringing about behavioral changes, and you are also preventing the youngsters when they grow old, the same genes, your chance of developing the disease is also there. It will also help them to have formed a healthy habit. It's easy to form healthy habits than to change the habit when they are grown up. That's a problem that we face.
I fully agree with this. I can add to it, saying that our generation is gone. There's no point in trying to change any of our habits, but we should be more concerned about the coming up generation. Okay, so they have to start the whole program from that's why it's specific about the school days. So if in the school, I think it has to be part of their curriculum. They have to, because there's no point in learning who all fought for the Second World War, who won the World War. Much more important is your health, your dietary habits and all. So that has to be incorporated as part of your education program and taught with carrot and stick, not carrots alone. Stick has to be there along with that. So I think then only the next generation, I think we can serve. Because I'm 17 now, and whatever I was eating at that age, I think I feel I'm not doing anything nowadays out of that. Not able to. That's because the whole group. Now, if you ask any of the mothers, can you send some of our old diet to your school for your kids to eat? They won't take. They won't carry it. Because if they go to school, they will be ridiculed, saying that, see, this boy is bringing all these things which are nonsense. They all try to adhere to all the fast foods. And they take it as a fashion of the day. And we are also happy because it's much more easy to get all these things from the bakery or hotel and give it than cooking at home. So that's what he was telling. So the change has to be, a big change. So I think that's the only way to save, and which has to be definitely started from your birth, fine, from the school days. I think that should be your attitude if you want to save the next generation.
For social setting, change is required, and in this conference first time we can see that this whole food plant-based diet is planned and we all are eating as a social gathering.
Sir, after your
last question, ma'am. Last question.
Last question. Okay. Breast cancer has become the highest in Kerala, and we Gynec Society are doing a lot, trying to have free breast clinics to detect this thing, as well as screening camps. I have also approached you. So after hearing your talk, I feel that prevention is to be given more importance. In that case, could you suggest some means where we can have a mass awareness of the women of how to prevent? Because as all this, in spite of all these lifestyle changes, the youngsters are going from bad to worse. They are having fast food, alcohol, and not breastfeeding, obesity. So how to initiate this? If we could have some sort of help from you, we would like to make a real change.
I think needs a big change. You know why? Just for your fun. Probably this may be the only conference happening in this hall without alcohol. Got the point?
Yes, sir.
Because what I told us, probably this may be the only conference happening in this hall without alcohol being served. So that will give an answer as to why this happens, okay. And regarding your even plan of action, for different cancers your action is going to be different. I told you for a lung cancer, 90% are preventable, but it's not screenable. There's no accepted screening way by which you can detect an early lung cancer. So your thrust goes on prevention. For a breast cancer, the thrust goes on screening because there is a high chance for getting screened for an early detection. And the dictum is, an early detected cancer, your chance of cure is 100%. Okay. And there's no direct relationship like tobacco with lung cancer, like you don't have any direct links to say that this is the cause for breast cancer. So that's the reason why we said when you speak about breast cancer, your thrust goes for a screening program. When you speak about a lung cancer, your thrust goes for a preventive program. For a social or for a society as such. Because you cannot say that just by going for a preventive program in the society, you can have a major impact on breast cancer. No. But you can have major impact on breast cancer when you are going for a screening program. For lung cancer, your thrust is going to be on smoking because just by preventing smoking, you are going to have a 90% cut on the incidence of a lung cancer. That's the difference.
So we are planning free breast clinics in all the gynecologics.
I know this. It's a major, I think, good move. You know the statistics like in 2026, we are expecting a incidence of 8,500 new cases in this state, breast cancer, 8,500. And that's why I showed you regarding the change in our, lifestyle which has gone for this, and it's going to be a major number, and it's equal to any of the developed countries in the world. That's why I told you, every third female who comes into your OPD with the cancer is coming with a breast cancer. Yes. Huge number. Age-wise, it was a disease of 40s or 50s. Now we have got girls coming at the age of 20, 25 years. Ample number of them.
Yes, sir.
I think your move is very good. I think it should be something which has to be appreciated.
Thank you, sir.
Thank you all. I now invite the chairpersons to present the memento to the speakers. I request all of you to come to the center of the stage for the photo session and the handovering of the memento. Memento will be handed over to Professor Samuel George Hanstug and Professor Dr. V.P. Gangadharan sir. Thank you the chairpersons, speakers and all the delegates for participating in the session. Now we have the launch of NNF Lifestyle Medicine Wing for doctors and family. I request you all to kindly bear with us for a minute for preparing the stage for the launch of Lifestyle Medicine Wing. Thank you.
പറഞ്ഞിട്ടുണ്ട് ഇതിനകത്ത് പറയണ്ട അവിടെ അതായിട്ട് പറഞ്ഞു അനൗൺസ് സ്റ്റാർട്ട് അനൗൺസിങ് ട്രൈ ടു വൈൻഡ് അപ്പ് because already we are to wind up 40 minutes yeah no wait let us say everybody start announcing അത് കഴിഞ്ഞ് പുറകിൽ സീറ്റ് വന്നോളൂ സ്റ്റാർട്ട് അനൗൺസിങ്
So we move on to the inauguration ceremony. As a part of President's Action Plan, now we have the launch of NNF Lifestyle Medicine Wing for doctors and family. For the official launch, may I invite the following dignitaries. I invite Dr. V C Manoj, President NNF India. He is a Professor of Pediatrics and Head, Department of Neonatology, Lakshmi Hospitals, Cochin. I invite you, sir, to the inauguration ceremony. I invite Dr. Amit Upadhyaya, Secretary NNF India, to the stage. I now invite our Chief Guest of Honor, Dr. Samuel George Hanstead, onto the dais. Samuel George, sir, will be accompanied by Dr. Abhi Matthew, President NNF Ernakulam Branch. I request Dr. Abhi Matthew to accompany the Chief Guest. Now we have the guest of honor, Dr. Lakshmi Sundar, President, Indian Society of Lifestyle Medicine. I welcome you, ma'am. She will be accompanied by Dr. Vibin Abraham, President, IAP Cochin. Now we have the guest of honor, Dr. Sachidananda Kammat, accompanied by Dr. Murli Raj, Secretary, NNF Kerala. Now I cordially invite Dr. Sujitra Sundar, President of KFOG, onto the dais. I cordially invite Dr. Lalan Bharati, National President-elect NNF, to the dais. I invite Dr. Dinesh Tomar, Vice President and Chairman of Lifestyle Medicine Wing, to the dais. I invite Dr. Somashegaran Imbalkar, President-elect 2026 NNF, to the dais. I invite Dr. Riaz, who is the President of IAP Kerala, to the dais. I invite Dr. T.P. Jayaraman, President NNF Kerala, to the dais. I also invite Dr. Fessy Lewis, who is the representative, Foxy representative to NNF, to the dais. I invite all the following NNF National Executive Board members to the dais: Dr. Sanjay Wazir, Dr. Ramesh Chowdhury, Dr. Ramarao, Dr. Vishnu Mohan, and Dr. Palani Ammal. I invite Dr. Lopad Dalal, NNF Lifestyle Medicine Wing Co-Chairman. I invite Dr. Mimi, Vice President, KFOG, to the dais. I invite Dr. Sri Sailam Koturu, NNF Lifestyle Medicine Coordinator. Dr. Geeta Mekot, KFOG Health Mission Coordinator. Dr. O. Jose, the President-elect, NNF Kerala. Dr. Murli Raj, Secretary, NNF Kerala, to the dais. Ravi Shankar. Sir. We are moving on to the launch of the NNF Lifestyle Medicine Wing for the doctors and family. So, first is the prayer. All please rise for the prayer. For the silent prayer. Thank you all. All can please sit. Now we have Dr. Vibin Abraham, President IAP Cochin, for the welcome.
Good afternoon, everybody. Dr. Manoj VC, President NNF India. Chief guest Dr. Samuel Hansdeck, HOD Department of Lifestyle Medicine CMC Vellore. Dr. Lakshmi Sundar, President ISLM. Dr. Sachidananda Kamath, past National President 2015. Dr. Sujitra Sudhir, President KFOG. Dr. Riya Sai, President IAP Kerala. National President-elect NNF, Dr. Lalan Bharati. Vice President and Chairman of Lifestyle Medicine Wing, Dr. Dinesh Tomar. Honorary Secretary General NNF, Dr. Amit Upadhyay. President-elect 2026 NNF, Dr. Somshekhar Nimbalkar. Dr. Gracie Thomas, President COGS. Dr. Foxy Lewis, Representative Foxy. President NNF Kerala, Dr. TP Jayaraman. Dr. Ebi Matthew, President NNF Ernakulam President and Secretary IAP Cochin. NNF National EB members Dr. Sanjeev Wazir, Dr. Ramesh Chowdhury, Dr. Ram Rao, Dr. Vishnu Mohan, Dr. Palni Ammal, Dr. Lopa Dalia, NNF Lifestyle Medicine Wing Co-Chairman, Dr. Sri Sail Lam Kuttur, NNF Lifestyle Medicine Wing Coordinator, Dr. Mini, Vice President KFOG, Dr. Geeta, KFOG Health Mission Coordinator, Dr. O. Jose, President-elect NNF Kerala, and Dr. Murli Raj, Secretary NNF Kerala. NNF, a national body of neonatologists of India, for the first time is venturing into an innovative and transformative conference to better the lifestyle, our lifestyle with lifestyle changes. The basic concept, food as medicine, gut microbiota and its role in health and disease. So we at IAP Cochin are honored to be a partner with NNF and other participating bodies for the national launch of this venture. We today have an array of national and international faculty for this national conference. Dr. V C Manoj, the National President of NNF, deserves full appreciation for his tireless efforts over the past few months, starting from suggesting the menu without oil, food tasting, to name a few. Now coming to my duty of introducing the guests, let me first introduce Dr. Manoj VC, National President NNF. Sir has been instrumental in bringing about the importance of lifestyle medicine, a branch of modern medicine that uses evidence-based strategies to prevent, treat and reverse lifestyle diseases. As we all know, the current trend has been that the non-communicable diseases have come to the fore and it's been increasing, and the communicable diseases are drastically reducing now. So this is one of the flagship project as a President of NNF. I welcome you, sir. Chief guest of the day, Dr. Samuel Hansdeck, HOD Lifestyle Medicine CMC Vellore. This branch of medicine was born in 2004, and CMC Vellore holds the distinction of having the only department, first and only department in India. Sir emphasizes a holistic lifestyle-based approach addressing the diet, stress, social styles and purpose that restores balance and prevent chronic diseases. Welcome, sir, to this conference. Dr. Lakshmi Sundar, President ISLM. Madam is trained under Dr. S. Murali, a pioneer in salvaging limbs with people with diabetic foot infection in India. She is a social activist and works with Banyan, an organization which works for homeless mentally ill women in Chennai. She is a marathoner and a president of the Chennai Runners. Welcome, madam. Dr. S. Sachidananda Kamath, Central IAP President 2015, does not need any introduction to this august audience. He has been, sir, wears many hats and has been instrumental in conducting one of the best national pedicons in the history of Indian Academy of Pediatrics at Cochin last year. Welcome, sir, to this conference. Dr. Sujitra Sudhir, President KFOG. Madam is a renowned gynecologist from Kannur, and KFOG is one of our financial pillars for conducting this conference. Thank you, madam. Dr. Lalan Bharati, NNF President-elect. Sir stands tall in the field of neonatology and has been instrumental in adding more than 1,500 members to NNF. He played a key role in coordinating programs with UNICEF, WHO and Government of India. Welcome, sir. Dr. Riya Sai, President IAP Kerala, our ever vibrant and youthful, charming President. Sir has been at the forefront of many innovative programs like Yuva CME, Ping CME, to name a few. Welcome, sir, to this conference. Vice President Chairman of Lifestyle Medicine Wing, Dr. Dinesh Tomar, a neonatologist by profession from Rohtak. Sir has been the past Secretary of NNF in 2021-22 and Sir is very distinguished faculty in almost all neonatal conferences in India. Welcome, sir. Honorable Secretary General Dr. Amit Upadhyay holds the distinction of being one of the first DM neonatologists in his home state of UP and has been at the forefront of imparting many quality care for neonates in UP, and his research extends to vaccinology and also neonatal ventilation. Welcome, sir. NNF President-elect 2026, Dr. Somsekhar. He is well known for his research in neonatology, pediatrics and clinical trials, and his main area of interest is kangaroo mother care, neonatal pain and neonatal resuscitation. Welcome, sir, to this conference. Dr. Gracie Thomas, President Cox, a well-known gynecologist from Cochin. She has been associated with many prestigious hospitals in India and abroad. Welcome, madam. Dr. Fessy Lewis, he is a professor and head of reproductive medicine in Amrita and the president-elect of KFOG 2026. Sir is renowned for his and a very active member of KFOG and IMA Cochin. Welcome, sir. Dr. TP Jayaraman, President NNF Kerala. Sir is one of the senior statesmen from Palakkad and also the past state president of IAP Kerala 2021. Welcome, sir. Dr. A.B. Matthew, the president of NNF Ernakulam, my secretary, has put in a lot of effort behind the scenes to make this a unique CMA grand success. Thank you, A.B. Last but not the least, I welcome each and every one of you who, with your family members, have turned up in large numbers to make this unique CMA a grand success. Thank you.
Thank you, sir. I now invite Dr. Manoj VC, President NNF India, for the presidential address.
Respected Chief Guest of the Day, Professor Samuel Hansdale, is my teacher also in lifestyle medicine. Dr. Vanida Rahman from PCRM USA in her absence. Dr. Lakshmi Sundar, President of Indian Society of Lifestyle Medicine. Sachi Sir, past President of National IAP. Dr. Sujitra Sudhir, President KFOG. Dr. Riyaz, President IAP Kerala. Dr. TP Jayaraman, President NNF Kerala. Dr. Gracie Thomas, President Cox in her absence. And all my other dear friends and esteemed dignitaries from KFOG, IAP and NNF on the dais. Respected seniors, teachers and my dear friends. A warm welcome to all of you for this conference, although we have covered more than half since this was being envisaged as a half-day conference. To tell you the truth, when we decided to launch a lifestyle medicine wing for all doctors and family, because we neonatologists alone are a drop in the ocean if we want to change the practice. What we realized is that we ourselves are actually outdated in some of the information. So we thought we will have a workshop, 30 to 40 people. I had the honor of having very good relationship with two of the organizations I work with, other than of course my own NNF, and the other one is of course my own IAP. But then the key persons who actually can make a change, direct change, the obstetricians who actually make change, because we now say for us also, like life begins at the time of conception, and whatever interventions you do from that time will have impact. So the babies, I am basically doing neonatal intensive care. So whatever the mother eats, and now we have gone one step further, we say BMI of adolescent girls, since 2015, we say BMI of adolescent girls have a impact on the neonatal outcome. Straight away the mortality, they had suggested the value of 19 to 23 as the ideal BMI of the girl at the time of conception. And just imagine where we are. What is the BMI is not a very poor indicator, but that is what something that we talk in evidence. So all these three organizations, KFOG, IAP and NNF, we thought we will involve all of them. We will invite 5 to 10 persons from each of these branches, and then let them all come and let us all discuss lifestyle. But then fortunately or unfortunately, it turned out to be a larger number, and now we have almost nearing 10 times the number if you count everything. So that shows the interest all of us have in learning about this new branch of medicine. We are all experts in our area. Just to give you a background, there are 3 eras in modern medicine. The past era of expert opinions, the present era of evidence-based medicine, and the future of precision medicine. We are all up to date, and we all follow evidence-based medicine as per the relevance in our settings when we do our clinical practice. But in lifestyle medicine, unfortunately, 99.9999% of us follow the past era principles of medicine. Expert opinions. I have done a study, I have read a study, I have run a meta-analysis. I know everything. I have just gone through a transitional change in my health, and I know everything. So now I start giving lectures as an expert to my colleagues, patients, and to my professional organizations. So we are in the past era. At least if we do not go to the precision medicine of the future, can we go catch up with the evidence-based medicine? This is the whole idea of having this conference. I have also done we were actually interested in this, promoting this concept since 2017 when I was the president of IAP Thrissur. But then this is the first conference where we are not calling it a healthy lifestyle conference. We are calling it the new branch of medicine called Lifestyle Medicine Conference. Of course, that is there is already a society existing, ISLM, which is propagating this idea. But do we make a difference? That is what we need to really think about. Do we really make a difference? I should say no. What do we serve in our hospital canteens where we are supposed to promote health? Hospital is supposed to at least prevent health or treat health. What do you give disease in your hospital canteens? What about ourselves? Are we ready to walk the talk? We are not. So that is why we need to think beyond our comfortable convictions and biases. I like a certain type of food. So I want to find evidence for that, and then I will argue, have a debate everywhere. We are going back. Let's look at science, use wisdom over knowledge and progress. So that is the objective of this conference. I do not want, even though I wanted to strictly keep time, time is out of my hands. So now, and the threat has a cumulative effect on you because the lunch also gets delayed. So let's try to hurry up. So I thank from the bottom of my heart, from my organization as the president of National NNF, both the other partners, KFOG, we wanted to involve Foxy, but then this is, I mean, it's too small. I thought this was too small. I told it was small. So KFOG, and of course my own organization, IAP, for associating with us for this launch. We are just launching. There is no somebody leading. We are just taking the first, coordinating. All the doctors, or I would extend it further, all the healthcare workers who are interested in lifestyle medicine are free to initiate this process. This is only a launch of the movement, and we do not want, neonate is the smallest one, we do not want to take the lead, and lead anybody can take. We want it to go in the right direction. That's why we thought we should have experts in this field. That's why we got hold of the one institution that is doing this course in where it is the only institution where it is not an expert of past era. It is in the present era. There they talk about present era, the lifestyle medicine principle. So CMC Vellore, and my professor, when I did the PGDLM course from there, Professor Sam, Professor Herb, and the whole team of CMC are here. I thank all of them for agreeing to give us support. And we are fortunate to associate also with Indian Society of Lifestyle Medicine, who should be leading us in the future. I also thank Physicians Committee for Responsible Medicine USA, led by Professor Neil Bernard. Dr. Vanitha was here. So they were also giving us a lot of support. So all the 6 partners have equal role. I would say we take a lower role. All of them have equal role in making this conference happen. I thank all the organizations for associating with this, and all of you for having come here a beautiful Sunday to listen to this concept and then try experiencing the whole food plant-based WFPB, no oil, absolutely no oil in any of the dishes that you get today. Of course, there will be substitutes, they are healthy ones, and no sugar, 0 sugar diet, that is part of the conference. So, and the pinnacle will be the lunch. I hope it will happen properly, because we had a lot of worries. We were asking, none of the caterers in Cochin were ready to do this. Only, I mean, just to take a minute, the only person who said we will do it was Taj. We went at Taj. But then it was far beyond the financial viability. So then we got hold of our own organization, IMA, and then with the help of this thing, we made them do this. And now I am sure, we have done the food testing also. I am sure the menu is going to be as good. So again, apologies for taking more time. Thank you all. Let us launch this movement. Let us walk the talk. Talk about lifestyle medicine. Let us not talk about patients. Let's talk about how we will make the change. Let that be the beginning. So hearty welcome to lifestyle medicine. Thank you.
Thank you, sir. Now we have the launch of Lifestyle Medicine Wing by our chief guest, Professor Samuel George Hansted, Department of Lifestyle Medicine, CMC Vellore.
We had a lot of talks, so I don't want to give a lot of talks. I feel honored Dr. Manoj was able to invite us and our team to come here. So I just want to thank Manoj and his entire team and we don't interact with pediatricians. What has divided us is the age, adult medicine and pediatrics. So today is a historic day where the age barrier has disappeared and we are interacting with our pediatrician friends. Second thing I just wanted to tell is, Dr. Manoj talked about precisions. I'll say this is personalized, precision, and predictive medicines. This is the medicine of a new era, and this is something that you all are going to be involved in. Thirdly and finally, I want to encourage all my pediatrician and neonatologists and even obstetricians, because you bring life, and nurturing that life, preserving that life, putting this life on this earth so that they can live a healthy and happy life is really an onus on you. Adult medicines, we can have the benefit of what hard work you have done, but unless we all put ourselves together, I don't think so this would really go forward. So just want to congratulate all of you for having come here, and for Manoj for organizing this wonderful conference. Thank you so much.
Thank you all. I now invite Dr. Lakshmi Sundar, President, Indian Society of Lifestyle Medicine, for keynote address.
You caught me unaware. Anyway, thanks Dr. Manoj and Pooja for having us over. When you sent me that message, I was like really excited that something like this was being done. And I immediately told my directors that we should replicate what they're doing, and that's a fantastic stuff. Take lifestyle medicine to the physicians, get them involved as patients, as stakeholders. That's a phenomenal to have done. And I wish we see many more walking the talk and passing it on to their patients. And you know, I was just telling Dr. GR, we need to see a future generation where lifestyle modifications are not required, and this becomes the lifestyle. Thank you.
Thank you, ma'am. I now invite Dr. S.S. Kamath, past National President, IAP 2015, for his keynote address.
Good afternoon to you all. National President of NNF, my dear friend Dr. Manoj, Chief Guest of the Day, Professor Samuel, who would be the father of the lifestyle medicine in India, I would say that. My friends from the NNF office bearers and dear friends, friends from IAP Kerala, other sister organizations like KFO and other dignitaries on the dais, off the dais, dear friends. This is a unique conference. I would not say that it is a conference also, but it's a blend of a conference as well as a workshop. Workshop is mainly meant for getting things done and hands-on training and other things. Something mix of a conference where you get a complete picture of what is happening, evidence-based, and practice it towards what we can do as a doctor or as a member of the family. You all know, I don't have to go inside the 6 pillars of the lifestyle medicine, which has been from the nutrition, physical activity, stress, sleep. Just Google it, you will get all these things in the lifestyle medicine. Apart from that, the leadership of Manoj, I'll have to mention now, he has been practicing this for the last 10-15 years, and he has been trying to push this in the various forum, and now when it came to the NNF president, he could push it through the national level and make it happen today to inaugurate a wing of a lifestyle lifestyle management thing. Hats off to you, Manoj. A big cheers, because the reason behind, he believes in the right beginning, other than what he has talked in his presidential address, that we ourselves have to be convinced with what we wanted to communicate with others. That is where he has propagated, and we have the array of the faculty who have given with evidence-based rather than nothing just coming out with some figures and other things. It is all evidence-based. I really appreciate, and I feel that this should not stop with the Manoj here. My friends over there, in the NNF, all the next 3 years persons are there. Take this forward because neonatology is one of the forum where they have a very good networking as well as to take it forward through the government and the various sectors and make it happen that it starts with newborn, and we have the other arm, the gynecologist, and we have here the other extreme medical specialties like medicine and others. So both arms with neonatology, to take it forward, I wish that this will be taken for years to come and mark it this day, and Dr. Manoj, that this will be a day where a new system of medicine has been recognized by the organizations, specialty organizations, which are going to accept this and take it forward. Thank you. And a word about the Puja, who have been a supporter, a silent supporter, you might have seen here and there about the diet and other things. Really, both of them, that is not only Manoj and Puja is together they make it always happen, these conferences, this kind of conferences. I appreciate both of them, and I appreciate every member over here who are dedicated in making things happen, and you all come from all over the India as well as outside India, and really appreciate every one of you to make it happen, and as a person who have taken it by heart, by mind, and take it forward. Thank you. Thanks a lot.
Thank you, sir. Now it's the address by associated organizations. I invite Dr. Sujitra Sudhir, President KFOG, to speak a few words.
Good afternoon to all. At the outset, let me congratulate Dr. Manoj and Pooja for this wonderful initiative. It was really fantastic. And each of the speakers, they could inspire us. I can see all the shining faces who are motivated, and the diet that they have shown practically, how we have to continue. And when I took over as the president of State Gynec Association, I found that most of the doctors, they are so busy, especially gynecologists, looking after patients, they have no time to look after their own health. So my theme this year was, be healthy and then make others healthy. So that is why I chose a very able coordinator, Dr. Geeta, as the coordinator for our mission. And Dr. Geeta is an ardent fan of Pooja and Manoj. And she has converted many of us to this particular lifestyle program. And as Dr. Manoj said, it is from birth onwards we have to look after the lifestyle problems. Women from the womb to the tomb are victims of lifestyle diseases. Young girls become obese, they have PCOS. We know all over we are flooded with PCOS. As they grow older, they become infertile. We have so many infertility clinics nowadays coming up. And then when they become pregnant, they get gestational diabetes and pregnancy-induced hypertension. And later on, in the later stage of life, they get cancers due to the wrong lifestyle. So lifestyle is the answer for all our gynecological problems, and I'm so happy that this program has taken off in such a grand way. We are going to continue it all through, and we are planning 2 more initiatives both in South and in North Kerala, and we hope we will have the association of Dr. Manoj and Pooja along with us. Thank you so much for the opportunity.
Thank you, ma'am. I now invite Dr. Riaz, President IAP Kerala, to speak a few words.
So, respected chair of the meeting, Dr. Manoj, respected guests and my dear friends. So we always tell about walking the talk. I think here we have a couple, Dr. Manoj and Pooja, who is really walking the talk. We all speak a lot about healthy diet, exercise, but like Sachi sir told, now when he got an opportunity, he had taken everyone to task. Now there is an established wing of lifestyle diseases. And I think it is a life cycle approach. A neonatologist talking about non-communicable diseases. So it's a beautiful idea, and I think we actually has to incorporate our proven idea of the first 1,000 days into this concept. So we need to formulate guidelines for children also. So when we are talking about lifestyle disease, it is more into the adult medicine, but as everyone was telling, it should start from the womb. So the care of the infant, care of the young child, and care of the teens. So the lifestyle medicine departments also can take up the pediatric part also and incorporate such ideas into this. And I offer all the support from Indian Academy of Pediatrics Kerala chapter, and we will make this wing of NNF flourish all over the state and beyond. Thank you.
Thank you, sir. Now it's the address by the Foxy representative to NNF. I invite Dr. Fessy Louise to speak a few words.
Respected dignitaries on the stage, seniors and my dear friends. So I represent here as a Foxy representative to a Neonatology Executive Board and also the Secretary to the KOCHI Gynec Society. Even though I know Manoj and Pooja for many years, and also Manoj was my 3-year senior in Thrissur Medical College, I know how energetic and enthusiastic he was, so determined and proactive at that time also. But when, as Sachi sir told, how this new concept has been, we have been telling our patients, we have to improve your lifestyle modification in our gynec practice. But how far that, whenever we have to tell that, we tell that we see the dietitian, see the fitness expert. But when we face through this, we also feel excited and we have been rejuvenated that we have to also have to change. Our family also has to be undergo through this, and then it will be easy in our practice also. So this new concept is a very good initiative, and we will try to implement that into our associations also. As Suitra Madam told, we will be implementing to our Kerala Federation, our KOCHI association also. And we will try to make it into the national Foxy level also. So wishing all the best for this wonderful initiative by the NNF, especially by the President Manoj, and I hope that this will, as Sachi sir told, this will go in the memory this day when this has been initiated, which will be helpful for our patients and for our family also. Wishing all the best for this new lifestyle wing of the NNF. Thank you for inviting.
Thank you, sir. Now it's the address by the President NNF Kerala, Dr. T.P. Jayaraman. Sir, I invite you to speak a few words.
Respected President of National Neonatology Forum, Dr. V C Manoj, Chief Guest Dr. Sachidananda Kamath, all my dear friends and respected seniors. It's a great pleasure to have seen how this speciality of lifestyle disease has evolved and how Dr. Manoj and Pooja has walked the talk, as Dr. Riaz was telling. And I had been observing the way he had been working for the development of this lifestyle medicine all through these years in the IAP fora as well as the NNF fora. And I do congratulate Manoj for this, taking up this as an action plan when it came to the capacity of President of NNF India. And also I congratulate all of you for spending your time and participating in this major event of launch of this lifestyle medicine fora, and let me wish the very best for this lifestyle medicine wing which has taken birth on this day. Thank you for this opportunity and my best wishes to all of you.
Thank you, sir. Now I invite Dr. Abhi Matthew, President NNF Ernakulam, to deliver the vote of thanks.
Respected Chair, Chief Guest, dignitaries on and off the stage, I very well know that you all are looking for this moment of the vote of thanks. So signing off fast with everyone's permission, myself seeing for the first time such a jumbo dignitaries on the stage, and I would like to thank in one line from the bottom of my heart Dr. Vivin Abraham, IAP Cochin President, for his welcome address. Special thanks to Manoj Sir, President NNF, for allowing Kochi as the first place for conducting this event. Thank you to our chief guest of the day, Professor Samuel Hansdek, HOD Lifestyle Medicine, for your messages, and thanking especially for the keynote address, Dr. Lakshmi Sundar, and our mentor, Dr. Sachi Sir. And thank you for the full support of associated organizations from KFOG, President IAP Kerala, Dr. Riaz, Dr. Lalan Bharati, who has come right from Delhi, Dr. Dinesh Somar, coming from Rohtak. Thank you, Honorable Secretary General, Dr. Amit Upadhyaya, coming all the way, and Somashekhar Sir, coming from Gujarat, Dr. Fesi Louis, Dr. T.P. Jayaraman Sir, for all your kindful words, and also thanking all the distinguished persons who are sitting on the stage, coming from different parts of the country. And we are overwhelmed to see such a response from the delegates. I thank all the delegates who are physically present, and we are having online members who are watching across the country and from abroad. And without taking names, I would like to thank all the faculties who have given enlightening talks. And my sincere thanks to our sponsors and Metropolis Lab and all the staff of IMA House. We have been working day and night for the last few days. The AV sound system, the comparators, the catering, and my office secretary, CG. And last but not the least, thanking God Almighty for making this meet possible. Thank you.
Thank you, sir. The official launch ceremony has come to an end. Now, we have a roundtable session, confronting challenges in lifestyle medicine practice, a reality check, and the way forward. Please bear with us for a minute to arrange the chair.
Invite the moderators onto the dais. Project the slides and
So now we have the roundtable session, confronting challenges in lifestyle medicine practice, a reality check, and the way forward. We have the panelists, Dr. G. Rajendran, Senior Consultant Cardiologist, Coimbatore; Dr. Mini G. Pillai, Senior Consultant Endocrinologist, Cochin. I request the panelists to come upon the dais. Dr. Geeta Mekot, Senior Gynecologist, Kannur, Kerala; Dr. Ravi Shankara, Department of Physiatry, Amrita Institute of Medical Sciences, Kochi; Ms. Pooja Manoj, Clinical Dietitian and Lifestyle Medicine Professional. I invite the moderator for the roundtable, Dr. Herb Giebel, Department of Lifestyle Medicine, CMC Vellore. And we have the co-moderator, Dr. V C Manoj, President NNF. I invite the moderators and the panelists to come upon the dais.
Good afternoon. Good afternoon. It is a pleasure to be here, and I'm delighted with all of our specialists that we'll get some good answers and some good tips. We're running shy on time, so we'll try to move forward quickly. Let me invite those in the audience, if you have a question, please write it down and submit it. And what we will do is, as time allows, we'll select some of your questions and try and have our distinguished panelists also address them. But as we get started now, let's first go to cardiology. It's where the heart of the matter is. We want to know a little bit more about reversing heart disease and the role of whole food plant-based diet. So, Dr. Rajendran, please help us. In our area of statins and antihypertensives, what is the role of whole food plant-based diet in reversing heart disease, number one? And number two, how can cardiologists encourage more adherence to lifestyle?
Good afternoon, everyone. Am I audible? Whenever we come across a new drug, we are all excited because we know that the CVD comes down remarkably. For example, the statins and the newer antihypertensives, they bring down the CVD by around 30-40%. But what does not go through our mind is the remaining risk of 60 to 70%. That is what is called as residual risk. That residual risk is always taken care of by the whole food plant-based diet. The second point which I would like to emphasize is, this morning there was a presentation on the investigations, and there was a mention, I think the presenter missed out on the LPA and somebody, lipoprotein A, and somebody rightly pointed it out. In Indian context, it is said that the lipoprotein A plays a major role than the LDL as such. And the lipoprotein A is unfortunately not brought down by the statins. The other thing which is not very well considered is the small density lipoproteins and small density LDLs. The small density LDL is more atherogenic than the LDL per se, and the small density LDL does not come down with the statin usage, whereas it does come down with whole food plant-based diet. Well, and it is also believed both from the patient side as well as the cardiologist side that once stenting or a surgery is done, it's all that is, it's over. So now I'd like to quote one small study, that is the nitrate OCT study. This study was done in patients who had undergone stenting, and they wanted to follow up these patients to look out for what is called as a late lumen loss. There are a few cardiologists over here and the MACE. Okay. So here, these patients were put on two arms, one with beetroot with nitrate and nitrate depleted beetroot. So, and they were followed for 2 years, and there was a considerable difference in the MACE in people who were on beetroot based diet. So that goes on to say that the intervention or the drugs do not suffice in themselves, so we need to have some lifestyle modification where the whole food plant-based diet plays a major role. I'll stop here for the first question. For the second one, how to implement it. This morning there was a quite bit of discussion on few things like, for example, dairy and eggs and all those things. Incidentally, I think Dr. Sam also pointed out the AHA has come out with the figure of 7 and 8. Both the European Society of Cardiology and the American Heart Association have come out with both primary prevention guidelines for CVD. And both incidentally quote plant-based diet. So they encourage the usage of 4 to 6 servings of fruits and vegetables. So this morning the discussion was on things which should not be used, but I think we should focus on the things which should be used. So that makes people to follow it very easily. How many of us actually follow 4 to 6 servings of vegetables and fruits? Hardly a few. Then why was the discussion on things which should not be taken? Are we actually taking the things which should be taken? That is the most important thing. So in 2017, Lancet published something, this is a global burden of diseases, in which the top 10 reasons for heart disease, dietary causes were discussed. In that dietary causes, whatever was discussed this morning, sweetened beverages, your saturated fat, all those things come down as 6, 7, 8, 9, 10th causes. The first 5 causes are actually not taking enough of vegetables, not taking enough of fruits, not taking fiber. These are the main causes. Not taking whole grains, not taking legumes. So I think it's easier to follow a whole food plant-based diet if we actually focus on half the plate. You just move towards it. The cardiologist has to emphasize on that half plate rather than the ones which need not be taken. Second thing is, as a cardiologist, I don't get time to sit. I think this morning there was a discussion on that. Dr. Sam was saying we need at least 1.5 hours per patient. Dr. Lakshmi was saying that we need 1.5 hours. None of us actually have 1.5 hours for the patient. But it is important that we form a team. I have a team with me which consists of physiatrist, dietitian, psychologist, staff nurse, we have a social worker. I think it's easier to form a team. So once I see the patient, I direct them to this group of people who will sit with the patient and counsel. And 3 hours or 4 hours they spend with them. And once they come back to me, the results will be ready. I will be able to sum up in a very short period. I think this is the best way to implement it.
Thank you very much, Dr. Rajendran. Some of us here are very convinced that a whole food plant-based diet is the ideal way. Some of us are hearing it maybe for the first time or early on, and we're still a bit skeptical. And some of us will say, it's good, but how do we get anybody to follow it? That's impossible. So we have here today Mrs. Pooja, who is a dietitian, and we'd like to ask her, first of all, on the next question.
Next slide, please.
How? I mean, in your regular practice, how do you make this happen? How do you get patients to follow a whole food plant-based diet, or more whole food, or more fruits, more vegetables, more pulses, and maybe even some nuts and seeds? And with that, what are some of the key challenges that you face on this journey, which may help the rest of us know how to do this better? Share with us.
Thank you for that question, sir. So, of course, the role of whole food plant-based diet in improving health and managing chronic conditions is well established and actually advancing. And the challenges that I face is one of the most important. Like, everybody now thinks that they are somehow protein deficient, and when I advise on whole food plant-based diet, so one of the concerns that comes up is how do we get protein, or how do we get some nutrients, there will be nutrient deficiency. But a well-planned whole food plant-based diet, you can actually address everything. And about the protein, somehow people think, even from the well-to-do families who are eating good food, even actually they come to us seeking protein diet, how to get enough more protein. So the first thing that I do is assess their protein intake and advise them on the, in lifestyle medicine, actually we do not think of a nutrient as a single nutrient, but the food quality, the food matrix, what we are eating, that is given a priority. The nutrient density is given a priority, and the metabolic impact that the food has is given a priority. So we actually explain them about nutrient density, the impact on gut health, and how it reduces inflammation. And like suppose if, and especially when people think about protein, they are actually thinking about eggs, milk, meat, dairy, all these, fish and all these things. So we tell them about the food package, what it is coming along with. For like animal protein, it's high in saturated fat, as already discussed. They are low in water content, so the calorie density goes up. And also they come along with uremic toxins like TMAO, already madam discussed, and IGF-1 and all these things. And whereas plant protein, they're high in fiber and anti-inflammatory, they come along with phytonutrients, micronutrients. So, and of course they'll reduce the risk of chronic diseases and also help in longevity and all that. So we explain them all these things. And beyond, other challenges are ultra low consumption of fruits and vegetables, especially the green leafy vegetables and fruits. It's very, very less. So we have to explain to them about how many servings, and we have to. And another thing is, like, people think that it's very boring, or it is for a short time. It is a diet. So all these things needs to be addressed. That how they have to make it into a lifestyle. So we provide them with recipes, interesting ideas, and moreover, it has to become, we have to guide them on behavioral strategies. So it's not just a one counseling that will do the job. They need to be in contact with us for some period of time, at least till the time they learn the intricacies of all this, to sustain all these changes.
And tell us, on average, what is your success rate? When you encounter a client, what proportion of clients actually make some positive changes in the right direction and improve their health?
What is the number of percentage who makes actual changes?
Approximate.
Yeah, so maybe 15 to 20% of the people.
3 to 20%.
15 to 20%.
Oh, 15 to 20%. So that's like 1 out of 5 to 1 out of 6. Okay? So if some of you are also working on the same journey, and you discover, I only have 1 out of 4 patients that are even listening to me, or some other number. Remember, our specialist here is saying about 1 out of 5, 1 out of 6 is actually ready to make some changes. It may be because of motivational interviewing issues. It may be because they really aren't ready. It may be a whole slew of issues. We're on this journey together. As you have answers, help us all, and we'll keep growing. But I appreciate Mrs. Pooja helping us here, because this is an area that we all struggle with. Thank you, Mrs. Pooja.
And,
go ahead.
Yeah, so it's a journey actually. They can come back maybe after a few months again when they realize something. So it's a journey actually.
Thank you. So we've gone from the heart of the matter in cardiology to working with our team member, our dietitian, and now we come to the inpatient setting. So we want to ask Dr. Ravi Shankara, what are the biggest challenges of implementing lifestyle medicine in a hospital setting, and how can you overcome that? You can follow that up with, what are the essential lifestyle changes that you've seen to prevent, manage age-related issues such as sarcopenia and frailty that affect longevity? So first of all, hospital setting, and secondly, as we deal with our elders.
So, hospital setting is the antithesis of whole food plant-based. You work many hours at a stretch, you have to sit in a chair or just do procedures over and over again. The simplest thing is, when you're out of the hospital, you take care of yourself so you can take care of other people. It's that simple. There's no other good answer for it. The lifestyle changes to prevent and manage age-related issues starts with us just doing it on our own. So, until I joined the lifestyle medicine course at Vellore, I didn't exercise enough. I learned that I'm not doing enough, so I do more. If my work hour is 12 hours in a day, when do I? Before I get into work, after work, and after morning class with the students, we make them exercise. So in the day, I get in 4 to 5 minute sessions of exercise, and I can keep my body okay. The biggest thing we find with people who are elderly...
So let me just interrupt for a moment.
Yes.
I want you to carry your thought on through. But we notice that what Dr. Ravi Shankaran says is that the first step on the inpatient service is he himself started to take steps to help himself have a better health.
Walk the talk.
Walking the talk, which has been the theme of the conference.
The last answer is for sarcopenia and fragility. As we get older, muscle gets lost, fat replaces it, and we have people who have lived their entire life, their kids are having kids, they see no need to do more. So they enjoy what they like, and that's eating more rice and getting fatter, right? So the simple thing is, if we are living according to the 6 pillars of lifestyle medicine, doing exercise, eating whole food, plant-based, when we tell them what to do, and they ask us, how do you do it, we can tell them what we've gone through. One. The other thing is how to incorporate exercise at this age. So there's an emerging concept called VILPA, Vigorous Intermittent Lifestyle Physical Activity. Whatever you do already, you add an exercise into that. If your work in the day is to hang laundry, you stretch a little bit more as you put the laundry up. If you're going to reach down and get a pot, you squat a little deeper. And in that way, they're maintaining their body in ways they would not otherwise.
Thank you very much, Dr. Ravi Shankaran. Let me just remind you, if there's any question that you would like to ask this panelist, please write it down and submit them. And after the next one or two, we'll ask someone to collect them. And please share them with Dr. Manoj, and he will select which questions we can answer with the time that we have.
Whatever questions you want to ask, because of shortage of time, please write them and hand over. We will ask at the appropriate time or at the end of the thing. We have the limitation of time which all of us agree.
So we've talked about the heart of the matter. We've gone then to involving our lifestyle team, and the team can be so important to the inpatient. And now we want to ask Dr. Geeta about women's health. We've heard a little bit about women's health already and the importance there. How much physical activity is really needed by women as they enter midlife and beyond to really make a difference to help them in their journey of halting, treating, and reversing chronic disease?
Before she answers, I need to really admire Dr. Geeta, because she is there in our group who joins every day at 6. We have a online fitness session from 6 to 7, and she joins regularly, so she walks the talk. So I think she is the best person to answer this actually.
Very good afternoon to all of you. Middle age, maybe from 45 to 55, as we go through, we can do minimum activities, whatever is possible. Actually recommended it is 150 minutes per week of aerobic activity along with strength training and balance exercise. Aerobic activity can be walking, brisk walking, cycling, jump, dancing, then team games like football, cricket and all if possible, badminton. Strength exercise to improve our bone strength, muscle strength, to build the skeletal muscles, so that we will be able to get up from the chair or from the ground when we age. When we are in 70s, 80s, we should be able to walk, get up from our place. We should be able to do activities alone without support. That is the aim of doing activities from the middle age. Balance exercise will prevent falls in future. When you learn to balance, like simple things we can do, stand on one leg for 1 minute 3 times daily, will improve the bone density so that it will fall, will prevent fall and improve our balance. Small examples we can, like when we see people around, we can tell our patients and the medical representatives who come around, we can tell them to small things to reduce weight and do exercise. Small things I used to do, I used to tell them, reduce 5 kg and come, so that I'll write your medicines. And some people, just after 1 month, they'll reduce 5 kg and come. Then I'll have to start writing their medicines. These are small things we can do around to improve our health around the people, our friends, our colleagues. One of my colleagues told me, you will be alone in the world. Nobody will be there around you because you will be the only person living. We all will die because you're the only person doing exercise. I want all the people around me to do exercise and live happily, be disease free and walk around happily. Thank you, sir.
Thank you very much, Dr. Geeta. But I'm not going to let you get off the hook so easily. I'd like to take this one step further. Pretend for a moment that I'm a 50-year-old housewife. Our 3 children have been raised, they've left home, maybe 1 or 2 of them are married now. I've done a good job by everybody's standards. I don't routinely, intentionally get involved in any additional physical activity. Make a recommendation for a physical activity prescription for someone like me, as I've described.
She can walk, do brisk walking in the evening if possible, or she can do skipping. Skipping will be a good exercise for her.
How much, how long, how often?
Skipping maybe start with 20, around 100 to 200 in the long run. It will improve her skeletal muscle, heart health.
So I tried it last week, actually, before I came today, and after 20 skips, I was so out of breath. And now you're telling me I should do 100 twice a day?
Twice a day. With practice, they will improve. Walking may not be possible, going to the gym may not be possible. Skipping is a good exercise. They can fall without rope. If they're scared of falling, without rope they can do. Or jogging, jogging at the spot. Maybe to half 30 minutes to 1 hour. Start with 30 minutes.
So what, if I hear you correctly, what you're saying is, whatever you do, even when you start small, do something.
Yes.
And then gradually increase. Until we can reach the goals that you have mentioned.
I have so many patients doing 500 times. One patient is the one chartered account, he does 2,000 times.
Thank you very much. We've talked about the heart of the matter, we've talked about involving our team, we've talked about inpatient care, we've talked about women's health. Now we want to talk about if we were to do an immersive experience, where we go to an actual lifestyle center and spend some time there. How much of a difference does that really make in adherence and sustaining behavioral change goals to living healthier, enjoying life more, and shedding my chronic disease?
Before he starts, let me just introduce him. Dr. Enoch is one of the rarest breeds of us. He runs a lifestyle medicine retreat in the picturesque Kodaikanal. And he has been able to reverse various lifestyle diseases. We know that lifestyle diseases include all the diseases that have a chronic inflammatory pathology, like obesity, heart disease, diabetes, malignancy, and now even autoimmune disorders. So the big list. And he's one who has shown it in his practice. He has data which he has presented in various forums, where he has shown that if you are willing to undergo a change, some things will happen. And these things will remain with you. Maybe if you go back to your old style, then something at least will remain with you. So this is just to give an introduction of the great man, Enoch. Over to you.
Thank you.
Yeah. So we run a 2 weeks residential program in Kodaikanal. And we have designed the program in such a way that we are able to address the diet and lifestyle change. So in a day, the program goes like, it starts with a Thought for the Mind program, where we address the major issues, life issues, and how to handle those life issues and handle stress better. So in that program, we basically teach them how to change their perspectives to different aspects of life. And then we go on, we put them on a specific diet, and each patient has a specific type of diet. In our diet program, what we do is we take advantage of the different phytonutrients, and we make program for specific diseases. And then we have a health education program. And one of the things why we have success in long-term compliance, we have about 60 to 70% of compliance, and I would attribute that because of our health education program. We train our patients and we give sufficient information why they need to change and how it helps. And by the 4th or 5th day, they see their blood sugar coming down, and we had to taper their OHAs and insulin by the 5th day. And they get so excited that they are getting off medications. And that's another thing, it's a great motivating factor for them. And then we also have a lifestyle change program. We make them exercise, sleep on time, and also eat food on time. So it's a whole package of program that we have designed. And we started reversing diabetes, and then we could see patients with good compliance on long term, microalbumin coming down, urea creat coming down, better glycemic control. And then we started to work with other lifestyle disease, and we have been seeing very good results. So basically the compliance is because making them stay there, change their habits, educate them, help them to handle stress in a better way, and so we see very good results.
Thank you very much. So if this were generalizable, and we've only had 2 people's experiences, so we can't say it's fully generalizable, from the outpatient setting, if 1 in 5 to 6 may make some positive changes initially, versus up to 2 out of 3 in the controlled setting there in Kodaikanal where you work, we can see that when a person is in that controlled setting where they have a chance to have education and experience that without having other options, and everything is built in, that you have a much higher success rate during those 2 weeks.
Yeah.
But when they go back home,
so
then what happens?
That's something very important. What we do is we make things very easy for them. Now, number 1, we plan the diet in such a way that all the ingredients are easily available. Number 2, we make a schedule for them according to their work pattern, and we give it to them. So all they have to do is go stick it in their home and just follow the schedule. So some of these small initiatives from our side helps them to comply with the program better. So we look into the small gaps and take care of it.
So from your observation, what proportion of those people that have come to your program for a full 2 weeks, when they go back, they stick with the program 1 year later?
Some of my patients, about 10 years, 15 years, they're off medications, they're doing very well. And I have so many patients doing very well on a long-term basis.
But proportionately, do you have a sense as to, I have 100 people who have spent a full 2 weeks with me.
Yeah.
1 year later, is it 99? Is it 24? What proportion of those 100 patients, from your observation, do you think are still sustaining that a year later?
Definitely, I would say more than 60 to 70%.
So again, another two-thirds or so. Okay. Thank you very, very much.
Before we go on to the next question, I just have an announcement to make, in the sense that we had a discussion with Dr. Enoch. He has offered us to help the doctors and family. We could organize one such retreat for those of you who can afford, maybe 3 days, if 5 days is not possible, and then we could go as a group and we could have the next conference or maybe one of the conferences in his retreat in Kodaikanal, where we again do it on a longer scale. So this will be done when we have 3 organizations. We will discuss together and then we will see how we can fit in a date. Finding a date will be the biggest problem, but then we will have to find a middle road. Thank you, Enoch.
Thank you very much. Thank you. We've gone almost everywhere. The heart of the matter, inpatient, using our team, women's health. Often we neglect the women, to an immersion program in a controlled setting. Now I'd like to come to diabetes. Dr. Geeta, we often see that diabetes is really, for many people, a low-hanging fruit, where they can begin to fairly quickly begin to see some results from lifestyle medicine. What is the evidence that this is really the case, and that diabetes can actually possibly be reversed? And how do you see endocrinologists being able to put lifestyle medicine into practice in their practices, and maybe there may be some hints that the rest of us may take away as well.
So, thank you. And I really thank the organizing team for this opportunity. And as far as diabetes remission is concerned, it is really awesome that we are speaking about reversing diabetes and remission of diabetes, because I think when I started practicing an endocrinologist, diabetes was definitely an irreversible problem. So nowadays we are speaking of reversal and remission. So that itself is quite awesome. And how can we effectively integrate these interventions into routine clinical practice? What we have seen here, like in our August audience, I see people here who are swimming champions, weightlifters, long distance trekkers, dancers. So even with this sort of very active August audience, we see during this session so much doubts coming. Is this practical? We have been eating these things since so long. We have been living like this since generations. So why do you want to change? So you can see the resistance to change. I think the most important thing that is needed for us is spending time with the patient. You very elegantly demonstrated this. The time needed to counsel patients and their families properly. And sir, like you emphasized how important it is to have a team in place, because in clinical practice the doctor often does not get time to sit and talk with the patient so much. We know like hospitals are driven by numbers, and those numbers are not necessarily the numbers of healthy lifespan, the years of healthy lifespan. So the numbers which hospitals are driven by are really not the numbers of healthy lifespan added to the patient, but other numbers. So the most important thing I think is to have a very good team to work with. We need nutritionists, we need exercise prescription, people who can give exercise prescription effectively. And again, lifestyle, the importance of gynecologists, neonatologists, all the pediatricians in cultivating lifestyle. Like we know, seeing diabetes patients, I know how important the community is for an effective diabetes treatment. It is not only the doctor. The doctor maybe contributes 0.1% or 0.001% to the successful treatment of diabetes. The most important thing is the patient. The most important person is the patient. And for the patient, the most important people are so many other people who are there in their lives. So the education of the community as a whole. And now we have so much wonderful avenues, like we have social media and to convey the messages of healthy lifestyle. And I'm so happy, I was just speaking with some of the faculty today morning. When I started promoting veganism, there was so much resistance, and maximum resistance was from the medical fraternity. So see, basically this what Pooja was saying, enough calcium, enough protein, and again cultural and social factors. It is so invigorating to see this much of attendance on a Sunday afternoon, listening to this sort of. I would again like to thank your team, the team that you have trained for this opportunity in Kochi. I hope I answered the question which was posed to me. My answer is enough time, the team support who can give time to the patient.
So in summary, point number one is having an event like this and seeing over 100 other physicians and doctors of different brands and varieties coming together like this is more than a dream come true for you.
Definitely, definitely.
Number two, go ahead.
And I would say we have to carry this forward. It's not only this is how we spread the message in the community. It's not that it is not, we have progressed a lot in the last few years, and this needs to progress further. I am sure this event will be a big step in that direction.
Thank you. And you've reinforced the idea of a team effort and how the different members of the team can also reinforce and work together and provide more time to the patient. And then you touched on one more area, and the other area is community involvement. And as those people that we are working with become members of or have a sense of belonging to a community of other people who are on a similar journey, it encourages each of them to move forward.
Definitely.
And we still have a lot of work to do, as you have said.
Definitely, like probably even with among patients also, probably we can have groups to motivate each other. This is what is usually done. When we have enough infrastructure, have groups who can motivate each other and have exercise sessions, such sessions together, all this will definitely help.
Thank you very much. I think there's a lot more that could be said.
I think we do not have more time. So, I don't know. I mean, like already, I mean, we are, I can get feedback in various forms from the delegates to wind up the session. I'm sure this is a panel of experts in their fields. There is no end to the discussion. We wanted to have more time, but then no, not enough. I mean, 1 hour is even not enough. That's how it goes. So, Herb, you can take the call.
I would like to say a great big thank you to each of you and to all of you for your patience. You can talk with them afterwards, maybe over lunch or sometime, to answer your own questions. But thank you so much for sharing.
Thank you all.
Thank you.
I now request the moderators to give the token of appreciation, the memento, to the panelists. I now request our moderators to give the memento to Dr. G. Rajendran, Senior Consultant Cardiologist, Coimbatore. I request all of you to come to the central stage for this photo. I now request I now request Dr. Hibbs. I now request Dr. V C Manoj to give the memento to Dr. Herb Giepel. I request Dr. Herb Giepel, sir, to give the memento to Dr. V C Manoj. So that comes to the end of the session roundtable. Next we will be having one more small session, that is...
We need to earn your lunch. So those of you who can take up the challenge, please come forward, and I request the committee to please remove the chairs from the front. Those of you who can take up the challenge, just move your body a little. Always make it a practice, earn your lunch. And what is the price that you pay? You actually, the reward that you give to your body, that make sure that you are ready to eat the lunch. So, please remove the chairs from the front. And I invite all of you to come. The instructors for this are Pooja Manoj and Dr. Namita. Dr. Namita, please come. Please remove all the chairs from here.